So the session today is to talk about advancing the care of the child with continuing critical illness. So sorry about that. As Dr. Parshuram said, technology is changing, and the whole point of the practical series is to talk about this is the 50th anniversary of critical care. And certainly a lot of things change in 50 years. And this isn't 50 years ago in the ICU. This is more like 20 years ago in the ICU. And you can certainly see that a lot of things have changed. The technology has changed. The bed spaces have changed. The cribs look almost the same, but otherwise everything looks very different. So the question is, what is continuing critical illness? What is it that everyone here has signed up for today? So to start by talking about what continuous critical illness is, first we have to talk about chronic critical illness. And this is something that's been defined in the adult literature as if you've been mechanically ventilated for 3 weeks, that's it, you have chronic critical illness. And in pediatrics, we're not just little adults, and we don't really think that it's quite the same. And basically, for our purposes, somewhere between having an acute critical illness and having been in the hospital for some period of time and supported with mechanical devices, there's a change in the emphasis of care, and there's a change in the role of families. And you change from being a parent to being an integral player in the healthcare team. This chronically critically ill is just one small part of a bigger umbrella. And this is more so what continuous critical illness is, which is a patient or a child with special health care needs. And some of these patients are what we describe as being medically fragile, which means that they're dependent on some kind of device, or they have some kind of developmental challenge, or they have multiple chronic diagnoses. And so it's this population that we're going to focus on today. And the reason that this is an important topic when you're talking about the 50th anniversary of critical care is that this is an increasing population. It's a population that is at risk of different challenges with their development, with their physical bodies, with their emotions, with their behavior. And it's a population that is going to need additional healthcare resources and management strategies that are specific to them and to their families. So the goals of the day I've listed here, which is really to talk about what does it mean to have continuous critical illness and what are the outcomes of these patients, and to really reflect on what is the impact of this not only on the healthcare team, but on the family and as our society as a whole. And to talk about practical, yes, pun intended, strategies for working with patients and their families. So what does this look like at SickKids? So we looked at our data in the ICU in all patients that were born after 2001 and looked retrospectively between 2001 and 2015. And during this time period, there were 17,889 admissions to our ICU of almost 12,000 patients. And this made up 110,000 ICU days. So you can see that the number of ICU admissions are increasing over time. And if anything, the ICU's length of stay is actually decreasing with time. When we look at these patients overall, their age on admission to the ICU, the median is not quite 1 year. The majority of them are male. They stay in the ICU for just about 3 days, and the median admission is 1, maybe 2 admissions per patient. Now, we wanted to focus more specifically on the patients that are dependent on a device. So when we looked at the number of patients that left the ICU on non-invasive ventilation, that was 2.6% of this population. Having a tracheostomy at discharge was just over 1%. Tracheostomy and ventilation was 0.5%, and dialysis was 0.1%. Focusing specifically on the tracheostomies, we can see the number of tracheostomies per year that were initiated in the ICU and the percentage of patients with a new tracheostomy. And you can see that although the number of patients in the ICU is increasing, the percentage of patients with a tracheostomy initiated in the ICU is around the same. So when we look at this, I'm going to walk you through this slide, but basically the point of this is to say, I don't know if you can see my cursor, you can't, that the majority of patients on the bottom axis is the number of days they're in hospital when a tracheostomy is initiated in our ICU. So the majority of patients on the right axis, or the left axis, sorry, the proportion of patients, the majority of patients when they're admitted to the ICU with a new tracheostomy are in the ICU for less than 10 days. And there's also a significant proportion that are in the ICU for 10 days or more than 130 days. And we look at that orange line, which is the total patient ICU days when there's a new admission for tracheostomy. I told you that there were 110,000 ICU days in that 14-year period, and 1.1% of our patients had a tracheostomy. However, there were 6.7% of the total ICU days that were devoted to these patients with a new tracheostomy. But I don't need to tell you that having a continuous critical illness extends past the ICU. And I wanted to talk about some data that Dr. Amin published in the Canadian Journal of Respirology in 2015, looking at this population and transitioning from the ICU. So of the 61 patients that we talked about in this period of time that had a tracheostomy and ventilation, she looked at 35 of these. The majority of patients had a tracheostomy and ventilation initiated for chronic respiratory failure, and the majority were extubated either 0 or more than 3 times prior to tracheostomy. The median number of days that they were in the ICU prior to initiation of ventilation with tracheostomy insertion was 54, and then from time to discharge was 62. So a total hospital time of median of 125 days. And I thought it was interesting that more than half of these patients were discharged directly to a rehabilitation hospital. And then from there, in the entire duration of acute hospital admission to discharge home, we're talking of a median of 240 days. And then when you get home, the days until you come back to hospital was a median of 149 days. So these patients are staying home, and the admissions per year on ventilation is less than 1. Then I wanted to talk about the fact that her N number at the beginning is 35 and now 27, because 6 of the patients in her study period actually died. So looking at patient mortality in the ICU, it is decreasing over time. The mortality in 2001 was almost 8%, and in 2015 is 3.5%. And when we combine that as a total, it's 6.7%. And the mortality in patients with tracheostomy or non-invasive ventilation, is pretty much the same and slightly higher for tracheostomy and ventilation. So to talk about getting the day started, the mortality rate in the ICU is decreasing over time, and we have an increasing population of patients with special health care needs. And when we're talking about the next 50 years in ICU, it's important to understand these needs and implications in terms of care. So where do we start? Dr. Parshram already went through the plan of the day, but quickly, the next thing that we want to do is transition to talking about exactly what these devices are that are supporting our patients from a perspective of the healthcare teams and including the parents that are an invaluable part, actually directly interacting with these technologies, eating, and then talking about what happens after discharge and working together to generate ideas for how we can make the next 50 years of critical care better. Now, bear with me as I transition back to the other slides.
Thank you very much, Jessica. Are there any questions as we transition back? Any questions or comments? Is this surprising data to those of you? No? 6.67% mortality, so 1 in 19 patients treated in the ICU over this period dies. Dr. Kavanagh. Mm-hmm. This might be a beautiful segue into the into Dr. Amin's talk, but let's do that.
We looked at we did one study looking at outpatients for children with medical complexities. So we looked at children who were requiring long-term ventilation, so either invasively or non-invasively. And then we chose a control group of children who were using G tubes. And what we found actually was that this was caregiver reported quality of life using a Health Utilities Index 3. And interestingly, actually the reported quality of life via parents of children with long-term ventilation was significantly higher than those of caregivers of children with gastrostomy tubes. And when you try to sort of delve deeper, it really seemed to be that what was driving the reported quality of life was actually neurological impairment. Because when you look at the subscales of the Health Utilities Index 3, that was sort of where we found the best correlation. Having said so, I think there's a spectrum, and I think the hard part was a small sample size, a biased sample size in the sense that the majority of these patients were non-invasively ventilated versus invasively ventilated is sort of direct reflective proportion of what we see in our program. but it was surprising nonetheless. So good morning, everybody, again. So I'm going to talk for the first 10 minutes or so. I'm the initial opening act, but the real star of the show is over there, Cristiano and his mother, Francine, who are going to take it away after. It's very informal, so please, if you have questions while I'm talking, just interrupt me and ask them, okay? So as Jessica already so eloquently said, that the population of children using long-term mechanical ventilation at home, these ICU graduates, really is growing. And there's multiple factors that are contributing to this growth. Really, it's improved medical care thanks to sort of frontline ICU care providers. It's also a result of advances in respiratory technology in homes. So the ventilators that we have available to care for patients are significantly more sophisticated than they were previously. We are appreciating the patient-centered benefits of care. And of course, there's a perspective of family-driven goals of care. So this is data from an epidemiological study that we did of our Sick Kids Home Ventilation Program over a 20-year period of time. And the blue is non-invasive ventilation, and the purple is invasive ventilation via tracheostomy. And what you can appreciate here is really the significant growth in this population over time. But interestingly, it really is largely being driven by non-invasive ventilation. So that's the blue bars. With the purple bars, that's representing the invasive ventilation via tracheostomy, which you can appreciate there still is growth of that population over the 20-year period, but really the biggest driver is the non-invasive ventilation population. So in terms of our long-term ventilation program here at Sick Kids, so who are the patients that we care for? So we care for children who are either at risk of hypoventilation or children who are using respiratory technology to support their respiratory hypoventilation. So we have a total of 223 patients, 90 of which are using bilevel, 34 are invasively ventilated via tracheostomy. We have about 14 who are just tracheostomy. 86 are on cough assist. There's several others who are using Airvo, so heated high flow, or supplemental oxygen. And then we also follow a cohort of about 60 children, mostly neuromuscular children, who are at risk of imminently developing hypoventilation. In terms of our program, we run a clinic once a week on Tuesday afternoons. We also have started a joint multidisciplinary clinic with ENT, also respiratory therapy, and also speech and language pathology that Dr. Chang and Faiza are also involved in. So it's called the Tracheostomy Education and Communication at Home Clinic. And the focus is really on tracheostomy caregiver, so patient, parent education and safety, and also with communication, so use of speaking valves and assisted speaking devices, which we don't seem to be able to get to in our sort of standard clinic visits. And then we also run a transition clinic program with West Park, which is sort of our adult counterpart in terms of ventilation provider. So in terms of our team, I'm sure all of these are familiar faces to everybody in this room, but just going left to right is Dr. Asil Alawadi, who's one of our long-term ventilation fellows, Joanna Polyview, our nurse practitioner, Dr. Jackie Chang, who's sitting at the back here, and you're going to hear from her later on today, myself, being 36 weeks pregnant there, Faiza Syed, an RT, Twing, also an RT, and then Dr. Athari Al-Majed, one of our other home ventilation fellows. One of the things that I really want to impress upon everyone, I think you can see from Cristiano and Francine being here, is that we all talk about patient-centered care, but really in this population, our patients and our caregivers are really integrated into our care team. And really, these caregivers are extraordinary parents and caregivers, and they truly are the experts in the care of their child. Francine knows more about Cristiano's medical care than I do. I'll be the first to admit that. The parents and the families really are the most valuable players on our team. And what we've tried to do in the last 5 years is really listen to them and focus on what are the key things that they have raised to us as being key priorities that we need to help support them. So long-term ventilation is really a novel new program that's emerging. And there's not a lot of resources for this program. There's not a lot of infrastructure. And so really we have to work with advocacy. So a couple of things that we've developed are a long-term ventilation discharge pathway to help sort of streamline that process from initiation of ventilation to discharge home. And Dr. Chang is going to talk about that in more detail. We've developed a Kids Vent tool, which is a checklist to assess caregiver competency in a standardized way. We've developed an online training manual to support standardized education. We've worked in collaboration with several parts of the hospital to develop the Health Tech Junior course, which is training modules that are offered for home care providers. And then also we've developed the Canadian Thoracic Society Canadian guidelines in this population. So the journey from initiation of ventilation to home is incredibly complex. It's lengthy. There's many, many moving parts. And so we developed a hospital policy and procedure, which you can access from your PNP site. And Dr. Chang is going to go into this in much more detail, but just to highlight for you that when you go to the PNP, you can click and download this pathway. It's operationalizing the different steps that need to be completed in a swim line style fashion. So you can see not only are there steps that need to be done, but it also outlines who are the care providers that need to be completing those steps, just to make sure that you know who's doing what and to ensure transparency throughout the process. We've also developed a accompanying family pathway so that when Faiza and Joanna are going to meet with the families for the first time and going through sort of what life is like and what to expect with the journey, there's something sort of tangible to look at to help guide these parents through. Family caregivers provide the majority of care for these children at home, and they really are, like I said, experts in their child's care, not just in their regular parenting stuff, but also in all of the medical stuff. That's Cristiano, who just said that's me. So family caregivers really need to have the knowledge, skills, and judgment to manage all aspects of care. And the training really should be standardized. And believe it or not, when we looked at this about 3 or 4 years ago, there really was no rigorously developed checklist to assess caregiver competency in this population. So we worked with about 100 different pediatric home ventilation clinicians to develop such a checklist, and it's called the Kids Vent Tool. And it basically breaks down all the skills and knowledge competencies that are required for tracheostomy care and also for ventilation care. And you can get them through stores. The Kids T Tool are the tracheostomy skills, and the Kids Vent Tool is for the ventilator-specific skills. In partnership with About Kids Health, and Faiza has been a huge part in terms of the development of this manual. We've developed an online training manual for the families. So this would be an excellent resource for ICU frontline providers when seeing these patients at the bedside. So you can Google it just through About Kids Health and voila, it'll appear. And essentially it teaches to that Kids Vent checklist. If you click on it, you'll get this sort of drop-down menu. You can select a chapter and go on, and you'll see sort of a summary of what key information we teach the families and caregivers that they need to know about this technology. And Francine can attest to this, and probably a lot of what she's going to talk about is going to cover this, but I would say that 95% of what we talk about in our clinics with these families relates to the issues with home care nurses. So families are eligible for home care nursing, and Francine sent me a link a week ago or 2 weeks ago saying that now there is no upper limit on the number of hours that families are eligible for, which just sounds like music to our ears. However, there's really two big issues with home care nurses. The first is that the home care nurses are not well trained. So families often have to provide training. We often have to provide a lot of ad hoc training. The nurses often wake up the parents if there's an issue. And again, those nurses are there so that parents like Francine can sleep at night. And there's also significant variability in the definition of what constitutes a trach-trained nurse. So for some agencies, it's the nurse being able to manage an emergency block tube. For other agencies, it's being able to suction a tracheostomy tube. And there's no standardization across the province for this. Secondly, even if you are lucky to get your certain quota of nurses, there is a limited pool of nurses. So if one nurse quits, another goes on maternity leave, another is sick, then those shifts go unfilled and the families are left. So one of the ways to try and address this, and in partnership with the hospital executive, the Learning Institute, Complex Care, our long-term ventilation program, and respiratory therapy, we have worked to develop the Health Tech Junior full-day course modules that are being run out of the Learning Institute. So these are full-day courses that provide a mix of didactic practice sessions with equipment and also fidelity simulation. So there's 3 modules, and in fact, there's actually module 1 is running today as we speak. So the module 1 is tracheostomy care, module 2 is ventilation and airway clearance, and Module 3 is enterostomy tubes and vascular access. And luckily, we've been able to secure some support for this, and therefore, we're excited to say that we're going to be able to expand this course indefinitely and also be able to provide care training to unregulated care providers and also as refresher training to family caregivers. Now, the reason why that's so important is up until now, the majority of children, well, all of them receive nursing care at home, but now there's going to be a push towards self-directed funding, which means families will now have the option to get a lump sum of money where they can go out and hire their own caregivers. Okay, you can see it's FISA doing her didactic training session. This is just some quick pictures to show some of the simulations that we run. And because we're able to do this in Learning Institute, there's sort of one-way glass and scenario debriefs afterwards. And last thing I want to say is just to highlight that there's now, through the Canadian Thoracic Society, there's pediatric home ventilation guidelines. And we worked hard to develop these guidelines really to ensure that whether you live in Flin Flon, Manitoba, Kenora, or in downtown Toronto, if you are a child of a child receiving long-term ventilation, you really are entitled to the same quality of care where you are across Canada. So hopefully having a document like this helps other clinicians across Canada advocate for similar resources, regardless of which province you're in. So that's all I have to say, and I'm going to turn it over to Francine and Cristiano.
Hi, I'll introduce you. So, ladies and gentlemen, boys and girls, children of all ages, I would like to introduce to you the sights you have never seen before, Cristiano
Hi.
My name?
It's Cristiano.
Let's see if we get this. Is it working?
No.
Here, you want to use this one?
Okay, we can use this one. I don't want this one.
This one doesn't work.
You just hold this one in front, okay?
This one.
Okay, now you can say,
Hi.
and what are you going to talk to us about today? I'm right here. So, what we're here to talk to you about today is, we'll make it really brief actually, because all this stuff that you just heard about, all the stuff to prepare us to go home, allows us to do this. It allows us to have the everyday life that we need to have. But we wouldn't be able to do it unless we were fully prepared. So if you come by and you take a look, we have all the equipment that we take with us every day when we're going out and about. And you can tell us, what did we do yesterday?
We went dinosaurs one.
And what did you do there?
I went on rides.
And he had a great time. We went on rides. He's a thrill seeker, so he loves his roller coasters. But again, we wouldn't be able to do that unless we were fully prepared to be able to go out and about. And that full preparation, what comes from the stuff we did in the 507 days we were in the ICU. So he spent 507 days as an inpatient in the ICU. Think of those 507 days as me sitting down and talking to you as a nurse or a doctor. It's 507 days for preparation to go live outside the hospital. So when I look at you guys and I think about what I want to say to you guys, it's about preparing us for the rest of our life outside the hospital. We love that you care for us and you took care of him and he was fantastic, that we got to leave the hospital, which not everyone is, but it's also 507 days of preparation to be independent, in control, and living the life that we want to live as families. So that's what I want you to think about when you come by our booth and you ask us questions. Ask us those kinds of questions. What was it like to be next to us in the hospital? What did you say or what did you hear? Those are the types of questions that'll help you prepare for the next patient that comes through your ICU door and you prepare them for life outside the hospital. All right, can you say thank you and say, please come and talk to me?
Thank you. Please come and talk to me.
Okay, so thank you very much for inviting me today. So my focus is a little bit different. I've actually focused obviously on venous access and critical care, but it's really the initial steps and really the initial kind of decision-making processes and what implications those have longer term. So as we're all aware, vascular access, venous access is absolutely fundamental. It's essential for modern medical care, and it's ubiquitous. Pretty much, I'm sure everybody who comes into the ICU and practically every person who comes into the hospital is going to have some form of venous access. One of the problems with something that's so fundamental, that's so kind of day-to-day, that's so mundane, is that we kind of forget about the decisions that we're making. It just becomes automatic, and we don't always think through the process. So I wanted to just take a couple of minutes to talk about kind of some of the key elements that go into the decision-making process when you're trying to sort out what kind of a line might be best for the patient, and what complications can arise from those, and how the decisions that you make actually can affect the complications that arise from venous access. So one of the first things to consider is, are there other alternatives? Is there another way of giving the medication or other things that we don't need to do that through venous access? Obviously, the answer for that most of the time is no. Really, what we need to think is, what are the risks and the benefits of making these decisions? And that's because no device is without risk. Nothing is without risk, but when it comes to venous access, that's certainly the case. And we seem sometimes to be fighting the "it's just a PICC" syndrome. So over recent years, we've actually been placing more and more PICCs. So the number of PICCs that we place is going up. The number of double lumen PICCs that we place are going up. And similar to the ICU, the dwell time for these is actually going down. So we're placing more PICCs for shorter periods of time. There are a number of different devices that are available for venous access. So I think everybody's familiar with IVs, so I'm not going to spend any time on that. But one of the newer devices that I'm not sure that a lot of people know about are long dwell IVs. And basically, there's a longer, softer IVs that come in 4 or 8 centimeter lengths. They're placed similar to an IV, but in a sterile fashion. And they can actually last for several weeks. So we've had patients who have lasted 2 to 3 weeks with a long dwell IV. So all of a sudden, maybe if you've got somebody who needs 10 days of therapy, maybe they don't need a PICC line. Maybe we can get away with one of these long dwell IVs. From an ICU setting, you guys are all very familiar with jugular and femoral lines, so I'll kind of skip over those. Med lines were something that were used in the past. They were kind of short central lines, but there was such risk, they were so high in complications, they're not really used anymore. And in interventional radiology, we do a ton of image-guided PICCs, central lines, and ports. There's still a lot of divisions within those, though. So, there's power PICCs, there's antibiotic-coated lines, there's vortex ports, there's singles, there's doubles, there's all kinds of choice. So it's really difficult to kind of navigate your way through this. And, in a 10-minute talk, I certainly can't give you the information that you need to do that. But I just wanted to talk about some of the different decisions that you do make when you're coming up with a choice of venous access. So I think the first thing to think about is, do you need central access, or can you get away with peripheral access? And the first thing to really think about is, what's the therapy that you're doing? What medications are you going to be giving? So if you're going to be giving vesicant chemotherapy, if you're going to be giving high concentration TPN, then obviously you're going to need central access. Another thing to think about is, what kind of infusion rates? How are you going to be giving the therapy? So, if you've got a patient who needs dialysis, if you've got a patient who needs pheresis, obviously you're going to need a much larger bore line. You're probably going to need central access rather than peripheral. To me, there's kind of 3 separate categories. So there's the temporary, the IV type things, the femoral and the jugular lines, and more permanent lines. And we consider PICCs and CVLs and ports to be in that category. So obviously, the duration of therapy is very important when you're making this decision. So if you've got something that's going to be happening several months, you need good, solid access. I also mentioned here intensive access, and that's a little bit kind of weird to say. I just wanted to share a story with you. So a couple of years ago in clinic, I saw a 14-year-old girl for a completely different indication. And she actually shared with me that she had had a PICC line as a child for 3 days of antibiotic therapy. And she has post-thrombotic syndrome. So the arm where she got the PICC actually is swollen, it's red, she has issues with exercise, and all of this was because of 3 days of antibiotic therapy. So it sometimes seems like people think like we're being resistant to placing lines, but there's reasons behind it. That being said, you also need to look at the individual patient. So some of the endocrinology or metabolic patients will be certain times where they need blood draws every 45 minutes to an hour over a 48-hour period. So in those patients, we'll actually place a PICC because you don't want to be poking a patient 50, 60, 70 times. Number of lumens, again, this is something we feel like we kind of come up with people against. Lines come in anywhere from 1 to 3 lumens. We can get triple lumen CBLs. I don't think they make triple lumen PICs, and obviously you guys use triple lumen lines here all the time. It's important to think again about the reason behind doing this. So, the nurses are way more aware of these sorts of issues than I am. What you really need to look at the medications that you're giving, the compatibility. If medications are not compatible, can you change the timing so that you can actually give one medication, give another one at a different time, or do you really need the double lumen access? Size, again, these are not independent variables. These are all kind of linked together. So again, looking at something like a dialysis line, you're going to need a much larger line than you would with somebody like an NICU patient. At the same time, if you have a small NICU patient, we try to place the smallest lines possible. But some of these patients might have hypoglycemia, need frequent blood draws. When you're getting down into the very small, like the 1.9 French, these are not always very good for getting the blood draws back. So sometimes you might have to go with a larger line depending on the patient situation. So I just wanted to spend a couple of minutes talking about complications. And again, I think we're all pretty familiar with the types of complications that we see from lines. So infection and thrombosis are kind of the big ones. We also see obstruction, dislodgement, blockages, arrhythmias. And unfortunately, we can also see perforation of the central structures, and that can actually lead to cardiac tamponade and even death. So just a little bit about thrombosis itself. So, thrombosis is affected by the size of the line. It's pretty obvious. The larger the line that you put in, the more obstruction to flow that you're going to have, the more chance of thrombosis. Interestingly, the number of lumens also affects the thrombosis potential. So by going from 1 lumen to 2 lumens, you're actually almost tripling the thrombosis rate, and that's independent of line size. The materials of the lines that we put in are also affect thrombosis rates. So the silicone types of lines that we put in actually have a lower thrombosis risk. The polyurethanes have a higher. The patient condition also does as well. So if you look at the bottom graph that I've got here, it's the thrombosis risk when it comes to the administration of different medications. And chemotherapy over on the right side is quite high there. So, it could be that the chemotherapy itself is causing thrombosis, but I think it's also potentially the patient themselves. These are very sick patients, their blood work's all over the place, and they tend to be thrombogenic. So the patients themselves can affect the outcomes of the lines. Similarly, with infection, the number of lumens, again, disproportionately increases the percentage of infections that you see. Uncuffed lines are more prone to infections, and again, the material. So if you're using something like a power pick, they're actually much more prone to infections than other types of lines. And I think it's the potential for things to be able to seed the lines themselves. And again, dislodgement, cardiac tamponade, all of these things can be affected by the choice of lines that you put in. So I just wanted to show you a patient that many of you may actually be familiar with. So this is a young child who, when he was 2 kilos in size, I placed an 8 French dialysis line in him. The reason for that is he could not have PD. The only way that he could actually survive was to place a dialysis line. So that was done. Within a couple of days, he actually developed a chylothorax. Here you can see that we had to place a drainage catheter to deal with one of the issues of having the line. Over the course of the next couple of years, we placed multiple lines in him. And as a result of placing these multiple large lines, we actually ended up clotting off both of his jugular veins. We clotted off his SVC. We clotted off his IVC, and actually his femorals as well. His femorals, for some reason, recanalized. But one of the unfortunate things for this poor fellow was he also blocked out his azygous vein. So he has no azygous, he has no IVC, he has no SVC, so he's basically got no way for blood to get back to the heart. So everything was really coming through some pericardial veins, which caused some obvious issues with his central pressures. And we believe this led to plastic bronchitis, which is a potentially fatal disease. So in order to try to deal with this, we actually took an 8-hour procedure, got people over from Toronto General to help us reconstruct his SVC. So from a technical point of view, we were successful. We were able to open things up again, but it was such a stress to the patient that they actually didn't survive. So, I think everything that we did here was reasonable, but to me, this shows that, sometimes a pick is not a pick, and sometimes it's a whole lot more. So we need to be very conscious of the decisions that we're making on a day-to-day basis and how they can affect patients in the long run. So I just wanted to spend 1 minute just going over a couple of resources that we've got in the hospital. So this was these 2 pathways were finalized within the last couple of weeks. So if there's issues obtaining venous access on an urgent or kind of emergent basis. There are now pathways in place. The one on the left is actually for the ICU and emergency room. The one on the right is for the floors. And basically, it's a very easy pathway to follow. And we have a really great resource within the hospital. So the vascular access nurses are very well-seasoned, kind of knowledgeable nurses who will actually be able to help you sort through a lot of the issues that arise. Okay. And I've actually got Debbie Kern here, one of the vascular access nurses, and Dalia Bozek, and these are two great resources for kind of helping you work through issues. Okay. And unfortunately, we asked for some parents to come, but we just weren't able to arrange for that to happen. Okay.
Thank you very much. Thank you, Sam.
Thanks everyone. Thanks for inviting us to talk, and I think it's a great opportunity for me, whoever is here, to say thank you very much for these 4 years and being involved with you guys in the ICU and doing the rotations, especially for the cardiac people, which I rotated with, but with everyone this year with EP. And there was maybe a miscommunication about the population, the audience, but I hope, at least from this talk, everyone can take at least one new point. There's, I think, a few people in the room that might teach me about pacemakers, but let's do it. So it's a very, very brief overview. In 10 minutes, it's very hard to talk about anything related to pacemakers, I think, but again, let's do it. So let's start with a case. It's a 5-year-old girl, previously healthy. It was July 24th. I just started my fellowship. She came to the heart station just to have an ECG after coming to the our ER for chest pain. The resident that was there was very thorough. He took some medical history. There were 2 recent syncope episodes that sound a bit weird. One of them while she was sitting on a couch with her mom. The other one while she was standing with no prodrome. That didn't sound like a vasovagal syncope, and it looked a bit weird. So looking at her monitor, again, I said that he was very thorough. He saw some skipped beats, so missing QRS beats, and he thought there's some second-degree heart block on monitor. We did the ECG, looking at the ECG. I'm not going to ask anyone, we don't have time, so sinus rhythm with sinus arrhythmia and right axis deviation. Not very impressive, but we did a 24-hour Holter just because of this story and the weird syncope episode. When she has high heart rates and active, exercising, everything looks okay, one-to-one conduction. While she goes to sleep or she has some vagal tone, increased vagal tone, this is how it looks. So you can see high-grade second-degree AV block. Some beats are conducted, some beats are not conducted, obviously, the P waves. And these are like 7 P waves that are not conducted. And diagnosis is high-grade second-degree AV block with a 5.1 seconds pause. What's the next step? So for the ICU audience, I expected like very easy. We have a great unit, admit to ICU, just start epinephrine infusion, isoprel infusion, and she'll probably get better, right? She won't have, during sleep, she won't have a block, but just a hint about the topic of this talk. So let's talk about pacemakers. So she clearly has an indication for pacemakers. So what are the main questions that we ask ourselves when we come to implant a pacemaker, or there's a question about implantation? Is there an indication for a pacemaker, for a permanent pacemaker? Because this talk is not about temporary pacemaker, which you see a lot in the ICU. What type of system is appropriate? Epicardial or transvenous? I'm going to mention and talk about all of these. Do we want to put a single chamber, dual chamber, triple chamber? There's such a thing, even in our population. Which pacing mode should we choose? You all know, we heard the VDD, VVI, AAI, VOO, etc. So pacemaker, I think this is the only picture you can find of a pacemaker without a brand name, like without doing any, you can Google it, there's like a million Medtronics and Jude. This is the only one where I'm not showing any name. So the pacemaker itself, as you know, the generator, what we call it, the box, it's a battery, which is hard to squeeze to an indefinite size or very small size. So that's why they still have some size for the pacemaker. There's a computer, the programmer. That's the thing that we wanted to coordinate all the sensing and pacing and all the programming we do to the pacemaker, and the header, the upper part of it, which we tuck the leads that we put in. So this is the generator. This is an old generator, a newer one, and the leads that go in during the procedure. When we put this transvenous system, you can see with this head and the little screw that goes out. So is this girl has an indication for pacing? We use the 2012 update for the 2008 guidelines. There's American guidelines and European guidelines for like anything else. In pediatrics, the common indication will be sinus bradycardia, which is symptomatic, and I think it's very important because we get a lot of referrals and questions, and also for us or for my staff, it's not always very easy to answer it. We have weekly discussions about patients, but symptomatic bradycardia is an important part. Bradycardia, tachycardia syndrome, very relevant for adults, very relevant for congenital heart defects, Fontan patients with flutter, and patients that we can use the pacemaker for anti-tachycardial pacing. And again, we don't have time to talk about it, but we can break some reentrant tachycardias with pacing. So we use it for both patients with sinus node dysfunction, especially post-Fontan patients. And as this kid has advanced second or third degree AV block, either congenital, as you know this population very well, kids with or mothers with lupus, with antibody-mediated disease, or post-surgical, sometimes even acquired Lyme disease, etc. So this is the indication, of course, and this girl got a pacemaker. So now when we decided to put the pacemaker in, what should it be? Epicardial, transvenous? Not sure that the difference is very clear. So we have two modes of pacing or two types of pacemaker systems. We can put the leads on top of the heart, as you can see in this. So the buttons or the leads come at the outside of the heart, epicardial leads the leads are being tunneled into a pacemaker, a box that sits anywhere in the subcutaneous, submuscular area in the abdomen or the chest. And there's a transvenous, the adult people know it very well, so they treat lots of people with this. But transvenous, the box sits somewhere, again, subcutaneous or submuscular in this area, in the subclavicular area, and the lead goes through the vein into the ventricle, into the atria, into both if we use dual chamber pacing. So for our very young kids, we don't want to use this very small vascular or vasculature that they have, the veins, for clot and for space. Very big issue in the EP world is lead extraction, which is very relevant for adults, but even more relevant for kids. What are we going to do when the lead ends his life? So usually we don't extract leads, either epicardial, which are stuck into the epicardium, and to take it out is a big thing, and the transvenous one as well. So to put a transvenous system in a kid, it will have every 8-10 years another lead and another lead and another lead. SVC is a big thing, of course. So for young children, we don't use it, so we use epicardial and not transvenous. If we don't have vascular access, of course, if you try to put a pacemaker in a Fontan patient, you're always going to get to the lungs, right? So these veins go to the lungs. So Fontan patient have epicardial system and not transvenous. And if there's an intracardiac shunt, ASD, VSD, there's a high risk mainly for paradoxic emboli, clot that will form on the lead and then it flies through the VSD or the ASD. And we have lots of discussions about these tiny PFOs, whether we should put or not. Usually we put a transvenous system. So what we do, the transvenous implantation, so usually we start with a venogram. We inject on the left arm, of course, if you want to put the pacemaker somewhere here, just because we are spoiled and it's easier for us to get the axis. You guys know how to do it without a venogram to get the subclavian axis. And then we get the axis exactly like you do in the ICU. We put a wire on top of it. The lead goes first. As you can see, the lead goes down to the atrium and through the tricuspid valve into the ventricle. When we are happy with the lead, you can see we're testing it. This is me when I have much more hair. No, this is Katie, the other EP fellow, and Dr. Stevenson, and they're putting a pacemaker. And when I'm not taking photos in the lab, I'm standing here. I should stand here and interrogate the lead. Okay, we see that we're happy with the lead, and when the lead, we're okay with it. As you can see here, we connect the box. We create a pocket beforehand, submuscular in small children or subcutaneous, and then we just stuck the pacemaker in. We check that all the system, we're happy with all the compartments of parts of the system, and this is the end result. These are the transvenous leads. You can see they have a screw or other systems that just stay in the myocardium for years. Also, our kids like to do slides and stuff like this, and they're very, very active kids for some reason, and we needed to be stay in place. We do the post-implant chest X-ray, and we again review all of the parts of the system that are intact, the leads, everything. For epicardial implantation, the surgeons, this has been done in the cath lab. the epicardial implantation is being done in the OR, of course, by the surgeons. We go there to help them. We test the leads, but they do the procedure. And the generator is, as I mentioned, the subcutaneous area in the abdomen, sometimes in the thoracic cavity when the kids are very small. I'll show a picture of it. And the leads are tunneled to the epicardial area, and they just put this button on the myocardium, on the surface of the epicardium into the myocardium, and we test the leads, and we're happy with it. This is an X-ray of an epicardial system, so you can see the buttons of a single chamber system. This is ventricular leads. This is dual chamber, so the pacemaker is down here, as you can see. The leads goes up. These are the atrial leads. These are the ventricular leads. This is a Fontan patient. In very, very small babies, as you can see, this is a 1.3 kilogram baby we had recently with congenital complete heart block. You guys took care of him. The heart rate was 45 during the pregnancy, and the kid is well and alive. You might meet him later on today. And we put the smallest pacemaker we had, Micro-knee, and look how it looks on the baby. And this was put in the chest cavity for him. We keep the patients here for 48 hours where we do periop antibiotic treatment. This is a big debate in our community about how long, and we don't have good enough data. Nowadays we do 48 hours. The only dose that we know that's really important and evidence-based is the pre-op dose, and now we're debating whether to do one post-op dose or keep the 48 hours, but that's what we do today. We do the X-ray, the ECG, we do a Holter to make sure that the system works well. We do a pacemaker programming and interrogation. And the most important thing we do is familial teaching that was mentioned here, the 500 days of staying in the ICU. So we use these days in the ICU and in 4D to teach the families what to do and how to treat the pacemaker and what is allowed and not allowed to do. I mentioned single and dual and triple chamber pacing. Again, a big debate whether should pace single chamber, a kid with complete heart block or post-surgical heart block, whether should pace VVI or DDD. And again, there's pros and cons for everything. We're a center that we do more VVIs maybe than others. So this is, one lead, and I just show here transvenous, one lead into the ventricle, one lead into the ventricle, and the other one stays in the atrium. And this is CRT, which means that we're not only maintaining AV synchrony, we're also maintaining ventricular synchrony in order to prevent some heart failure or cardiomyopathy or pacemaker-induced cardiomyopathy when we pace in single leads. So this is relevant for single chamber or single ventricle kids and dual and biventricular kids that they have, again, 3 chambers that are being paced, the right atrium, right ventricle, and left ventricle. This is an adult system that they put through the coronary sinus transvenously. We don't do it. We do like epicardial in the OR, and we go and do some mapping to understand where's the best place to put the 2 leads on the ventricles, where we get the narrowest ECG, narrowest QRS in the ECG. Pacing modes, you all heard. I'm not going to talk about it. You know that there's some letters, and these are the components of the VVI, DDD, AAI, etc. We can talk about it another day. The long-term follow-up after we finish these 48 hours, we taught the family, we send them home, and we want to see them back. So our pacemaker clinic at the 4th floor is a great clinic. I just came from there now. Very good atmosphere. Christine, which she didn't allow me to increase the size of her photo larger than this, is an exceptional person and a master in pacing, and I don't think there's enough superlatives in our team. She's the head technician and the head team for the heart station, and she knows about pacemakers more than anyone else in the building. And she knows the families very well, and it's a great learning opportunity for any one of you who wants to come there when we have a pacemaker clinic. You can see what we do. We interrogate the pacemaker. This is just a Google photo in order not to show patients, but we put these bagels. The magnet talks with the pacemaker. Of course, we don't talk directly, just through this interrogation system, and we can interrogate the pacemaker and change the settings. We look at the pace, thresholds and sensing and impedance and all the stuff that we don't have time to talk about. There are problems with pacemakers, as you know. There are acute problems like pneumothorax that you can see in this X-ray, of course. That's a good reason to do an X-ray when we get a subclavian access, etc. It could be, we could perforate when we're screwing the lead into the heart, the myocardium, and stuff that is acute. We also have some more chronic, like lead fractures and other stuff that can happen, you know, with time with a pacemaker. Infection is always a big concern for us. You know, there's different series between 1% and 3%, but it's always a big issue no matter what you do and how, you know, sterile and antibiotic treatment you do it. So this is just an example and a frightening thing for us and for the patient, because sometimes it has to be, you know, we have to take the pacemaker out and all the system. Of course, when you have a lead that goes into the heart, so every infection can become endocarditis. Just to mention ICDs, this is the only slide about ICDs before I finish. So ICDs are completely different stories. Every ICD is a pacemaker, so always two in one. It's a pacemaker and an ICD. An ICD, the idea of it is implantable cardioverter defibrillator. You take the AED that is on the wall and you put it inside the patient. The indications for it are different, are on the same document or same article, but the indications are different. Of course, we try to prevent sudden cardiac death, primary or secondary, after a patient had a sudden cardiac arrest. And the way we put them are the same, and the leads are the same. Instead of, or besides the fact that they have a coil on them, you can transduce this high energy shock that you want to terminate at a VF or VT. So same systems, epicardial or transvenous, single chamber, dual chamber, even triple chamber for ICDs. So these are the main differences, and we don't have a lot of time to talk to. They have this coil that you can generate the energy. This is one kid that probably Michael Alice remembers, is not here. We put an epicardial system on a patient that came with VT and had Epstein anomaly, so we couldn't get into his right ventricle from the inside, or we didn't want to increase his tricuspid regurgitation. This is just the injection. You can see the system. This is the atrial leads. We put a dual chamber CRT, epicardial way, so the surgeon put it. These are the atrial buttons. These are the ventricular buttons here. And this is the coil that you have for defibrillation. See, this is the black part is the coil. You can see this injection through the aorta in the LV, and this is the system. So we have some more complicated systems that we put. Any questions? Later on, we'll meet Katie. You'll meet Katie and Christine that I mentioned for this panel, or you can touch pacemakers and enjoy.
So thank you for this opportunity. I'll tell you how much I love the venue of the dyad of including a clinician with a parent. I'm officially on vacation. My daughter's getting married on Saturday, but I came here today because I love this venue. This is beautiful. So my name is Silvana, and I'm the G-tube nurse practitioner. And as you all know, G and GJ tubes are very accepted devices. The medical community embraces it as a very low risk and very efficient way to nurture and support growth, nutrition, and hydration for patients with all kinds of medical complexities. And so certainly, as such, we get requests for G-tubes and GJ tubes throughout the whole hospital, in fact, throughout the whole province. And I love speaking about the approach that we use for the consult. Essentially, the decision-making and the assessment through looking at the medical history and the nutrition and their growth history is really, by the end of the consult, to answer 4 questions, really. 1, does it make sense to proceed with a G-tube? What is the benefit? What are we trying to gain here? Has the team that's involved with the patient really explored every other alternative? And so when looking at a child who's intolerant of feeding, have they optimized reflux medicines? I'm looking at Kate. If a child has an oral motor dysfunction, have teams really looked at supporting the child and trying to evolve oral feeding progression in that way? Certainly there's an array of different reasons why we put G-tubes in. Some are more black and white, some are more straightforward, others a little bit more gray. So we really try to decide, has everything been done to avoid a G or GJ tube? And I think families really appreciate that, because they do want to know that everything has been done to avoid. But certainly if it is required, then the decision is might be, yes, this child would benefit from a G tube. Sometimes it's a GJ tube in children who have feeding intolerance. The second question that the consult has to answer is it safe to proceed with the G-tube. As you all know, they're all done under general anesthetic, and there are some children with, of course, very complicated histories where anesthesia is more, it is a risk. And so certainly we engage our anesthesia colleagues to help us with that decision. There have been times where we were not able to proceed with a G-tube because the risk of an anesthetic far outweighed any benefit that we would gain in inserting a G or GJ tube. The third question is it technically feasible? So most of our G-tubes here at Sick Kids are put in an IGT with just a small minority by general surgery. And of course, the procedure is such that there's a percutaneous approach, and so we have to actually access the stomach. And there have been situations because of anatomy where we could not place a G or GJ tube. So for example, the stomach might be hiding under the ribs in a child with a very severe scoliosis. We've been talking about pacemakers. I've had probably 3 or 4 patients where we could not put a G-tube in because the pacemaker was right in front of the stomach, so we could not access that tube, access the stomach. So that, that has to be considered as part of your assessment and your clinical reasoning around deciding whether to move forward with a G or GJ tube. And then the last question to consider is it something the family wants for their child? And I often argue that that's the most important question. Of course, Joanne is going to share her perspective on that. But I think, in talking to families about whether they want it for their child and whether they're ready to accept it, I've gained some great insight into the difficulty families have in making that decision to move forward with the G-tube, and the literature is very strong in supporting that fact. Families have a hard time with the G-tube and whether to move forward with it or not. And the reasons are so varied, for sure. I think I bear witness to that more than anybody in the hospital. I think sometimes too, families feel forced. That's always distressing to me, that a family feels forced to move forward with a G-tube for their child. Because for me, I think, certainly, as I said earlier, there are stronger indications than others sometimes. And if the indication is really strong to move forward with a G-tube, and then I think I'd rather, listen to what the family is saying, and then, carefully, I always sort of say, take them in their varied readiness state to accept, and really kind of try to get insight into what they're worried about and what is causing that decisional conflict. There is so many different things that worry families. It could be the complications, and as you all know, with patients who have G and GJ tubes, it's not just a simple G-tube. Oh yeah, we just put a G-tube. We could put the G-tube in, but there are all kinds of complications that can happen, and a lot of the complications that result in, admissions and difficulty at home. So again, the consult tries to answer those 4 questions. Is the child an appropriate candidate? Is it safe to proceed? Is it technically possible? And of course, engaging the family, and is this something they want for their child, which is, Joanne, take it away. We don't have a child, but we have a doll.
Yeah, no, Hudson's sick, so Hudson stayed home. So some of the things that families really face about this, and one of the reasons you get a lot of pushback when you approach a family about a G-tube, is eating and drinking. Those are basic functions to live. So when you come, you have to get upset. When you come and you tell a family, I promised Jess I wouldn't do this too, that their child needs a G-tube, you're saying that their child is failing at a basic human function, or that they're failing as parents to teach their children how to do that. And that's very hard. For me, when Hudson ate Hudson has a congenital heart defect, it's quite complicated. Before he came for surgery, he ate. He took a bottle, he had some NG support for that, but he did okay and he could eat. After his open heart surgery and 8 weeks in the ICU, he couldn't do it anymore. I'm the one that actually asked for the
G-tube consult. And I accepted that that was needed. But it was very difficult to sign the consent for the G-tube. I had signed 2 consents for open heart surgery, tracheoplasty, cardiac catheterizations, and the one that upset me, as you can see, it was the G-tube. It was really hard to sign. It was really hard to accept. And that's something that you all need to consider when you speak to families about the need for assistance with something that's so basic. Hudson also has other things. He's on oxygen support and other things that he needs help with. But the only one that he really cannot do by himself and is getting better now is eat and drink. So that's something you all really need to focus on when you are speaking to families. Other problems with G-tube, and these will not make me so emotional, is the expense. So when you come in, you're told you need a G-tube for your child, there's quite a bit of expense with that. Feeding pumps are $835 at the specialty food shop in Sick Kids. That's a lot cheaper than you can get them at a lot of other locations. So there's that initial expense. That is just the pump. You also need your feeding bags. You need syringes. You need the food. Commercial formula is now covered by OHIP Plus. If your child's on milk or other formulas, there's coverage for that as well. If they're not on formula, which I'll get to, then it's out of pocket. But all the supplies you need cost, for the first month your child has a G-tube, $1,000. So you're going into specialty food shop and you're spending $1,000. There are a lot of patients who come to this hospital who do not have $1,000 to spend. There is funding to assist with that through the Assistive Devices Program from the government. That funding can only be applied for the day your child gets a G-tube. It takes 6 to 8 weeks to get that check. And that check only covers a portion of the cost of the pump. And then every 3 months, you get another check that covers a portion of the cost for the supplies. It does not cover the entire cost. In addition to that, if you want to rent the pump, because you don't have those funds up front, by the time you get your ADP check, you've already paid your portion of the pump and then have to pay it again once you buy the pump. If you are an ODSP, if you're on Ontario Works, you do not get full coverage for these items for your child. So it's a big expense for families to go through this. The other big thing, Hudson's intolerant to formula, as many of his doctors are aware. He has a distinction of having vomited Neocate from an J-tube post-surgery, which is quite the thing to see. He can't tolerate formula. He is on a blended diet. Sick Kids has done a lot with blended diets. A study came out in January between the GI department and the dietitians that supports that blended diets are better than commercial formula for these kids and for people in general. I don't think that's a really big supply. I don't think anybody really wants to go and drink any of the complete formulas because they don't smell very good, and I'm sure they don't taste any better. But to make a blended diet requires equipment. The only blenders that efficiently do that are Blendtec and Vitamix. Both of them have medical discount programs, but it's still an out-of-pocket expense. If you don't want to wait for the medical program, Vitamixes are $500 at Costco. They're more expensive if you buy them somewhere else. It's another very large expense, but if you use any other kind of blender, it does not blend it smooth enough to go through a G-tube. J-tube children are also fed real food blended diets, and you need to be blending it even tinier. So think about that. Those are additional expenses. Then there's specific things that you need for the blending. You need the ability, if you go out with your child, you can't just run into a grocery store and buy them a snack. You have to bring all their food for the day. You have to have the ability to keep it cold. You have to have the ability to warm it up. You have to have the ability to flush their tube. You have to have the ability to clean the feeding bag in a hygienic way. All of these things are other things that you have to plan for that you do not have to plan for if your child eats and drinks orally. Even at the hospital, you are not able to have the hospital support a blended diet. That's both Sick Kids and McMaster. Hudson's been admitted to both. Or I make his food and bring it to the hospital every day, and the nurses are quite happy to administer it through the pump system. At MAC, they use a kangaroo pump. That will not work with a blended diet. So these are all other things that families have to consider when they're approached about getting a G or GJ tube for their child. And these are things that they really aren't going to think about in that initial consult where it's just about whether their child is able to take enough nutrition and hydration orally. And these are things that you as medical practitioners probably are not thinking about either in the long term, because most of these concerns and issues are raised when these families go home. Medical things about G-tubes are things like granulation tissue, if the G-tube moves around a lot, infections, things like AMD foam, which is an antimicrobial foam that we use to fight granulation tissue infections and all sorts of things. And these are recurring problems that are ongoing with G-tubes. This doesn't even get into if you go to a Mickey button, which is not covered at all. It's $200 every 6 months to buy a Mickey button for your child. So there's all these extra concerns and costs for these families when a G-tube or JJ tube is suggested. And those are things that you all need to really keep in mind when you're recommending this to your patients. Yes, Georgia?
I'm not aware of any study that actually looked at that empirically, but I know anecdotally families have come to me to tell me that when their child had an NG tube and when it was removed because a G tube was placed, they tell me that they've seen some wonderful evidence of further progression with oral feeding. In fact, to the point where we had placed a G tube in a little one who was orally averse, was dependent on an NG tube for months and months and months. As soon as the NG tube came out, because the G tube went in, it took this little one truly like 9 or 10 days, and which made me feel really badly, because I think we think very thoughtfully about whether to proceed or not. After the NG tube was removed, this little one just went to town. So unfortunately, there's no evidence, but we do hear it anecdotally from families.
So there's a couple of things, and unfortunately, the best way to sort of understand that is for you to actually put an NG tube down your nose and then try to swallow. Hudson's 16 months, he doesn't tell me these things, but I know from older kids, because all the parents talk. That's something I'm sure you're all aware of, that you'll have older kids, or if you speak to some of the older patients in the hospital, they can tell you how uncomfortable it is to swallow while you have an NG. The other issue that a lot of parents find is that as soon as you get rid of the NG, you end up being on a lot less reflex meds because the cardiac sphincter is not being held open, right? So if you do have regurgitation, it lessens because you're not having that being held open all the time. So that also tends to assist with kids who want to orally eat, and it also can affect their aspiration. There's a lot of children that will aspirate more frequently when their cardiac sphincter is being held open, which tends to go away when they stop having an NG tube.
Can I ask, just the supervision at night, it may not have been an issue for you, but if you've spoken to others, how does it impact this having easy feeding in terms of other moments? We've heard in the tracheostomy children there's nighttime supervision issues. Were there any for you or others?
So when Hudson was on an NG tube, he was fed by, overnight we did feed him. He's a cardiac patient. He needs a good number of calories in order to sort of maintain his weight and gain weight to get to surgery. So if he was doing a gravity feed overnight, I was awake while it was running. Different hospitals have different policies. McMaster doesn't have the same policy as Sick Kids with regards to pumps going home with NG tubes. Sick Kids policy is you can't have a pump with an NG because it's a safety issue for aspiration. I don't disagree with that. Other hospitals don't have that same policy and will in fact send a pump home with an NG tube. Hudson has never been, the only time Hudson's been on continuous feeds, he's been an inpatient, so he's had nursing monitoring, so that hasn't really been an issue for us. But Hudson also has no history of aspiration. So it is something that's discussed a lot, especially between different parents, because we all go to different hospitals, especially once you go home from sick kids and you're at your local hospital and they don't understand why you can't have a pump. And I don't think it's properly explained to parents how it's a safety issue and what sorts of things should be a concern. Because if your child is continuously being fed, the likelihood that they might aspirate at any time is a lot higher, especially if no one's tested them for silent aspiration, etc. And they would need, I would think that they do need supervision. Hudson luckily has not had that, so I haven't had those supervision issues. Yeah, okay.
You're right. It's not just a G or a GJ, but there are other types of tubes for sure. Yeah, yeah. I just wanted to touch on just the, I know we have to carry on, but on the idea that there is a whole world of parents talking to other parents. There is a network out there, and I think that, you know, they do want to hear from their clinicians. They do. I like to feel like they trust us. But families like to hear from other families as well. And so, and there's nothing sugar-coated. If a family is having a difficulty with a G or GJ tube and all the array of complications that can happen, they are certainly talking to each other. So it is best to, you know, talk about all those things up front, but, you know, also in that same breath, talk about the management of those issues and sort of bring to light that those things are manageable things. And at the end of the day, when we make a decision to proceed with the G or GJ tube, it is always because we believe as a team that the benefits far outweigh the risks or complications. So.
And I think one of the things that we, just as you pointed out, being a little mindful of time, there will be opportunity this afternoon being focused on notion of the indications to do things and the way in which the different devices are used and can benefit and inconvenience and the resources, human, personal, finance, and other. We're going to talk about the more, perhaps the complications and other issues associated with day-to-day and coming back to the ICU in the afternoon. So I'd like to thank you both for this, the beginning of this conversation.
Right. So I'm going to introduce to you a population of patients and technology that both Silvana and Dr. Temple are very familiar with, because you want to talk about tubes? My kids have tubes. So I have no conflict of interest, and I just want to say that the pictures are used with the express consent of the parent or the children for teaching purposes. Chronic kidney disease has no cure. And so the best cure, the best treatment is prevention. There's a growing body of data that says that survivors of acute kidney injury in the intensive care unit are at risk for chronic kidney disease down the road, and particularly the cardiac population. And when kidneys fail, there are basically two options. One is dialysis and the other is transplant, and patients cycle through these. And so things like growth and development, preservation of vascular access, these are all really, really important to my population. So I'm going to give you a whirlwind tour of the two types of dialysis that people do at home And I'm going to then show you a video in place of a parent, video done by a child or the parent of a child on home hemodialysis to give you an idea of the complexity of the care involved with these kids. So PD is based on the principle of diffusion, waste products moving from an area of high concentration to an area of low concentration across a semi-permeable membrane. So we use the lining of the peritoneal cavity and put a specially formulated solution into the abdomen. Waste products drain out of the patient and are then drained out of the body via various mechanisms. And good things come out of the solution into the patient. So it's bidirectional flow across the peritoneal membrane. In order to do that, you need a dialysis access and you need a solution delivery system. So the types of, I don't know if I've got a pointer here on the computer. The types of access that we use are these types of catheters here that are called swan neck coil catheter. They're put in surgically in the adults. There are some interventional radiologists who do them, but we haven't gotten to that point yet here, right, Mike? The catheter exit site position is really, really important. And we have kids with complicated anatomy. So this is the peritoneal dialysis catheter, this is the G-tube, and this is a vesicostomy. And so you need to get that exit site away from all of these other ostomy sites because these are dirty sites and this has to be a clean site. This is another baby who's got a vesicostomy and a PD catheter. And of course, in infants, we also need to get that exit site out of the diaper area because, as we all know, diaper areas are dirty. And even when my kids don't pee, they still poo, most of them, although some of them have ostomies as well. So this is a little guy who really shows you very well the intersection of technology here. He has a PD catheter right here, and he's got a G-tube there. Parents are very innovative at finding ways to protect that G-tube site. And you can see that he had a little knapsack with him the day that he came to clinic, and he very busily unpacked his knapsack and started playing with his feeding pump. And he's on a portable feeding pump because he's on J-tube feeds. Position of the catheter is really important. It has to be decided in advance. Abdomens are all very different. We have to keep that exit site away from belt lines and skin creases and so on because it's really important not to get infection, and I'll show you some slides that show you what happens. And in babies, we have to, male babies, we have to make sure that there's no hernias because once I fill that fluid, belly full of fluid, out pops the scrotum, and then we have to back off on our dialysis and send them to surgery. I've got some show and tell outside. If possible, people can come by and see it. But basically, once we put that PD catheter in, there's this little extension set here. This is called a titanium connector, and we use titanium because A, it can go in an MRI machine, and B, it inhibits bacterial growth, so it reduces the likelihood of bacterial contamination. And this is what the kids will go around with, this little transfer set, and then this hooks up to the dialysis system. It's really important that that catheter be immobilized, so there's all kinds of different devices to keep the catheter from wiggling around because that increases the likelihood of irritation at the exit site. And exit site care is a really important point of being, an important part of being on dialysis, that we don't want to get infections around the catheter exit site because that's a risk for peritonitis or need for removal of the catheter. People in ICU are familiar with the IPD setups, but we don't send patients home on these. We send them home on a cycler, and the one that we use mostly right now is the Home Choice Pro. I have a cycler outside that you can have a look at. There's a newer one that we're trialing right now that's got a slightly different technology. But basically, we teach parents how to use this cycler at home. The minimum volumes are 125 to 150 mils for the cycler. So if you have a baby, they're in hospital for anywhere from 3 to 6 months. The training time is 10 to 14 days. And these treatments are done at night. The older children may be as short as 8 hours. The average is 10 hours that they're hooked up to the cycler. And for babies, that may be as long as 15 hours at night. And that's quite often in conjunction with a G-tube feed of some description. Parents are trained not just how to use the cycler, but they're trained in sterile technique, exit site care, how to set up the machine, how to know what dialysis solution to use, how to recognize peritonitis and treat it, how to measure blood pressures, along with G-tube feeding. And it gets even worse when you talk about home hemodialysis. So for hemodialysis, we basically have two options. The majority of our kids are going to be on peritoneal dialysis if possible, because that allows them the freedom to go to school. But for many children, either the nature of their underlying illness or their circumstances socially make hemodialysis a better option. So there's two choices. One is in-center hemodialysis, where the kids come from home to see us, and the other is home hemodialysis. And this is Caitlin, who you're going to meet momentarily via video. So in order to have hemodialysis of any description, we need an access, we need a dialysis machine, we need a dialyzer, and most importantly, we need a water treatment system. And these are the things that people don't think about. We take tap water and convert it into sterile water without impurities that allows us to dialyze patients. And basically, it's diffusion therapy as well. So this is where Mike Temple comes in. Mike can put a garden hose in a 2-kilo baby. We need big volume lines in order to run high dialysis flows. And so, an older child on dialysis will have flows as much as 300 or 350 mils per minute. You don't get that from a peripheral IV. You do need a garden hose. And these are a couple of different lines, and you can see the chest x-rays with these lines in situ. We have a very limited number of patients who have what we call an AV fistula, where an artery and a vein are hooked up together to give you arterialized blood flow through the venous system. And this is an example of one of the kids on dialysis with 2 needles in the AV fistula. We need a dialyzer. They come in different sizes. And that's important because when we're taking blood out of the body, we have to try and design a circuit that's going to be less than 10% of the child's blood volume, so that we don't need to expose them to blood products. And the big workhorse is these little things called dialyzers, and I've got some examples out there if anybody wants to have a look at a marvel of modern technology. We need a dialysis delivery system that's going to run the blood through the machine and run dialysis on the other side of the semi-permeable membrane. And again, this is diffusion-based therapy. In center, these are the mechanics behind the walls that nobody knows about, really, or nobody thinks about. This is our intake system from City Water. These are carbon filters that are going to remove impurities. This is a reverse osmosis system, and this is the backup system. And when we come to ICU, or patients who go home on a conventional dialysis machine get a reverse osmosis system in their home, but we take these to ICU so we can treat your dirty water down there and make it clean. Not that your water is any dirtier than anybody else's. So these are a couple of kids on dialysis. It takes a village to look after these kids. What you can't see here is this is Ailubu right here, keeping this young one interested and occupied while she sits for 3 hours on a dialysis treatment. So these slides are courtesy of Caitlin, whose mom and Caitlin put together kind of what are the pros and cons that led them to decide to do dialysis at home. And so the pros of doing in-center hemodialysis, not much responsibility for the parents. The kids, it's very social in the dialysis unit. They get to meet celebrities. The parents have time to interact with other parents. But the cons are traffic, missed time from school. This is 3 to 4 hour treatments, 3 to 4 times a week. There's gas, there's parking. There's so many hidden costs with chronic illnesses, as we've already heard about G-tube feeds, and that's magnified when you're driving to the hospital, especially from a distance. So this was their daily routine, 7 a.m., 4 days a week, stuck in traffic on the Don Valley Parkway. We're all familiar with that. And so when they started to think about it, the pros of doing dialysis at home were less travel time. More dialysis means less diet and fluid restrictions, more family time. It means less time missed from school. But as always, there's cons. More responsibility and work for the parent, and you're going to see that in a minute. Lack of and interrupted sleep, and water costs. So dialysis takes a lot of water. and the water bill went up substantially. And there's very little way to recoup these costs apart from submitting them on your income tax, and we know how much you get back. There are some smaller machines that are more portable now. We are not yet using this one called the Next Stage, but it can either generate a smaller amount of water at home or use bags of solution. But Caitlin's on a, let me see if I can escape out of here and wreck the joint. So if you'll bear with me for 4 minutes, this is going to give you an idea of what this family goes through at home every day. So this is the reverse osmosis machine for the water treatment. There are some upfront costs. A lot of people have to do some renovations that the plumbing work is some all the supplies in your bedroom. We've got lots of cabinets to store the dialyzers and lines and all the different supplies in there. So these are the jugs of dialysate that mix with the treated water, and more storage in the basement. So it takes 45 minutes to an hour to set up for each dialysis treatment. This is Mom testing the water at the reverse osmosis machine. She's testing for chlorine in the water because chlorine is a toxin. Setting up the machine, so she has to set up dialyzer, tubing, lines, prime the system with saline. So there's that's the bicarbonate concentrate. Getting ready for heparin, because the child needs to be anticoagulated during the treatment. 45 minutes later, Caitlin's ready to go to bed. Getting her temperature done and her blood pressure. Did a good job fast forward. Recording all the pre-treatment data, accessing her central line. Sometimes it's a little positional, so she has to wiggle her head around to get the right spot. So this is in fast motion, as you can appreciate. All right, she's ready to roll. Going to sleep. Caitlin sleeps quite nicely through her treatments. Mom, not so much. And that's an issue when you're doing overnight therapies. We have night lights on the machine. 8 hours later, she's ready to come off. Caitlin's still asleep. Mama's up. Once a week, she has to get post-treatment blood work done. She has to take that from the lines. She has to centrifuge it. We're almost done. So that blood will get brought into the lab then. She has to TPA the lines. Sometimes we use heparin, sometimes TPA. She's going to wash back all the blood from the circuit, get the machine ready for cleaning, disinfection for the next treatment. Caitlin's still asleep. And then Mom tries to go back to bed for half an hour or so before the day starts. So 5 to 6 days a week, that's their routine. That's a little snapshot of dialysis. Yeah. Silvana. I tell you, I was impressed when I saw that because we know, but when it's in your face like that and you see the time that it takes people, yeah. But then that's the time that she spent on the Don Valley coming back and forth, and so mom's been able to go back to work. Caitlin's back to school full time, yeah. But it's not for everybody, as you can imagine.
And the video shows no issue, I mean, other than a little bit
The
of
line, yeah.
resistance. But what does this poor mom or what do these families do when in the middle of the night there are problems?
So it depends on the problem. You know, if they can troubleshoot it by themselves, if they can troubleshoot it by calling down to us. If there's a problem with the circuit, she had a circuit clot one evening, then you just you take her off and then bring her down, or you know, depending on how sick she is, mom can do a blood pressure and a heart rate. She knows whether Caitlin is unwell, and would bring her down in the middle of the night, call 911 if need be. But yeah. And you've got her blood volume circulating continuously at 350 mils per minute for 8 hours outside her body. We use Tego connectors so that if the lines disconnect, they won't exsanguinate, but yeah. Yeah.
Two questions. You mentioned mom.
Yes.
How involved are fathers in this process? And are there, and in a completely unrelated question, are there parents who find this fairly complicated thing more than they can manage?
Absolutely, and so that there is a selection process to kind of figure out what people are capable of doing. The father is not involved in this family. Their parents are separated. He does know how to do things, but it's mom who bears the brunt of the treatment. But yes, fathers will train whoever needs to be trained and whoever wants to be trained. Unlike PD, which it takes 10 to 14 days to train people, this is 6 weeks. 6 weeks of training, done usually when the patients are in for their regular 3-time-a-week dialysis sessions. And then there is obviously a fairly complicated assessment process to make sure that parents are able to do it. We do one treatment overnight in the hospital with the dialysis nurse sleeping here in the hospital, but with the parent doing it. And then the dialysis nurse does a home visit for the first treatment as well.
Do you train the tracheostomy care? We train only the 2 caregivers, just because the expectation is that there's more only 3 caregivers at the bedside. In general practice for the dialysis patients, do you visit one caregiver?
Yeah, and in adults, that may be the only person. It might be an adult living alone doing their own dialysis like that. Yeah.
Will the dialysis machine alarm if there's a problem?
Yes, yeah. But the kids frequently sleep through the alarms, both for PD and for hemo. Yeah. Yeah. Yeah, well, it depends. Some parents will, at least initially, sleep in the same room. Most of them, they'll use baby monitors so they hear the alarm. There's technology that allows them to do that. And there's leak detectors that allow us to detect if there's blood leaks or anything.
Thank you very much, Sylvia.
So the single most common consult that we get in the ICU, outside the ICU, in the emergency department, from home, from concerned parents, has to do with CSF diversion. CSF diversion is the most common pediatric neurosurgical procedure that we do, and placement of ventriculoperitoneal shunts is one of the most common surgeries that we do. It's also the most underappreciated. So oftentimes people say it's just a shunt, but shunts have a significant number of issues, and it takes a little bit of art and finesse to understand how to troubleshoot them, how to maintain them, and how to address challenges that arise. So today I'll be talking about some of those issues. So just as a overview, many of you know that hydrocephalus is excessive accumulation of cerebrospinal fluid within the head that's caused by some disturbance of either formation or flow or absorption of the CSF. And there are many, many causes, as you know, of hydrocephalus. The normal CSF production rate in an adult, which is more or less comparable in children, is 0.35 milliliters per minute, or 500 milliliters in 24 hours. There are many causes of hydrocephalus, as many of you know. There's congenital malformations and there's acquired causes. Those are typically the two divisions of hydrocephalus. So congenital malformations can range from aqueductal obstruction, from Dandy-Walker malformations, vein of Galen aneurysms, all kinds of things that, that children can be born with. And of course, acquired causes are very common. In the pediatric population, at very young age, the most common acquired cause is intraventricular hemorrhage, which scars the pathways that absorb the CSF. And as you get into older children, we see more aqueductal stenosis, we see more tumors, and we see some of the more adult pathologies that are described in this table. I thought I'd begin by showing a picture of a child here with hydrocephalus. I want you to remember this picture because I'll show the post-intervention picture in just a second, because one of the challenges that we are often faced with is trying to prognosticate outcomes after treatment of hydrocephalus. And it's really very, very difficult. I will tell you, and it'll become much more clear once I show the post-intervention image, but this child has a completely normal life. This child is intellectually normal, is physically normal, and is doing very, very well out in the community. But this is the first CT scan that this child presented with. And clearly we see that this child has triventricular hydrocephalus, meaning the lateral ventricles, the third ventricles are enlarged, but the fourth ventricle is actually normal sized, it's small, suggesting that there's some obstruction between the lateral and third ventricles and the fourth ventricle. So to treat this child, there's essentially two options. And I know that there's some residents in the room, so I thought maybe a resident can discuss this case with me. Who's a resident here? Maybe put your hands up. Any residents? No? Fellows. What do you think?
So, the CSF diversion that we consider here, the terminal shunts versus temporary versus a more permanent option if there's infection.
Perfect. Yeah, excellent. So you know, assuming that we're going down the permanent route, as you say, the ventriculoperitoneal shunts is really the standard, the tried and true method of treating hydrocephalus, but there's also another option that I'll talk about very briefly, which is? Yes, that. Perfect. Wonderful. Wonderful. Endoscopic third ventriculostomy. And when to do one versus the other is always you know, very interesting for us anyways to talk about. But this is the most common indication for it. This is the child that I showed. This is just a sagittal slice of their CT scan. I showed the axials earlier. And you see here that there is a tectal tumor. This is the tectum, the superior and inferior colliculus. And there's it's expanded. And it's compressing the aqueduct. So the lateral ventricle, the third ventricle is enlarged, but the fourth ventricle is small. So if the CSF can't flow down the aqueduct, we can create another pathway for it to flow just anterior to the brainstem into the prepontine cistern. So this is the ETV. I had a video, but it's actually not showing on this computer, but that's okay, because this is an endoscopic view into the lateral ventricle. This is the choroid plexus here. The thalamus is here, the septum is over here, and right in there is the floor of the third ventricle. And what we do is just make a hole in the floor of the third ventricle and give the CSF another pathway to flow from the third ventricle into the subarachnoid spaces where it's absorbed, but instead of going through the aqueduct into the fourth ventricle and then the subarachnoid spaces, directly into the subarachnoid spaces in front of the brainstem. So that's always an option to keep in the back of your mind. For one reason or another, I can't quite recall, we did put a shunt in this child. And this is what a shunt procedure looks like. It's essentially a small incision up on the head, and it's a small incision up down in the belly. And we pass a catheter into the ventricles. The catheter is connected to a valve of some sort, and there's many different types of valves. And it's something that really interests pediatric neurosurgeons, but no one else, about which types of valve to put in, for what reason, and what are the indications. Is it programmable or non-programmable? But it's all a valve. It all opens up under a certain pressure, or it has a constant flow rate where it's always draining. and it drains down into the peritoneum. And I showed you the pre-CT scan. This is the post-CT scan. So sometimes you can have a dramatic effect on these children's lives by just treating the hydrocephalus. And as I mentioned, most of the time, the imaging cannot predict how they do. This child is completely normal, living a full life in the community. So a small procedure that can have a huge effect on a child's life, but it needs to be well understood by neurosurgeons and everyone who's taking care of these children. So this is what one shunt system looks like. This is the ventricular catheter that goes into the ventricle. This is an old type of shunt that has a reservoir that's attached to the burr hole. So the burr hole is here, going into the skull. The ventricular catheter is here. This is the valve, and then the distal catheter goes into the peritoneum, and we have some models that we can show you and talk about a little bit afterwards. The challenge, of course, becomes, now that I've showed you that shunts are great and they have a important role in the management of hydrocephalus, is how to troubleshoot a shunt when a problem arises. And a problem arises very frequently. Depending on why you put in the shunt and the age of the child at which a shunt is inserted, there's about a 40 to 50% failure rate at about 3 to 4 years. So we tend to have a saying that if a child goes 10 years without needing some shunt intervention, they probably didn't need the shunt in the first place. They're very, very prone to failure, but unfortunately they are the best device that's available for the treatment of hydrocephalus, aside from an endoscopic third ventriculostomy at this point in time. So when a parent comes in with a child that has a shunt problem, the most important thing is really the history and physical. And I tend to tell our residents, med students, fellows, that a shunt exam, even though we really trivialize shunts more than we really should, is probably the most in-depth exam that most in-depth history that you should take from a patient. Why was the shunt implanted? When was it implanted? What was the reason for the hydrocephalus? What's the setting of the shunt? What do previous failures look like, both clinically and radiographically? How has the story changed over time as the child has changed with the shunt in place? All of those things are critical to trying to understand what's going on when a child comes in with a shunt failure. So again, indication for shunt, number of revisions, their dates, the complications, the types of valves, the settings, and then of course, we're all familiar with the exam primarily focused on signs and symptoms of raised intracranial pressure. But in children that have shunts, oftentimes even very subtle neurologic findings can be indicative of a shunt malfunction that may not be exactly textbook, as I'm sure many of you have seen in the ICU. So investigations of shunt malfunctions include CT scans, plain x-rays of the shunt system, palpation of the shunt reservoir, which is something that a lot of people talk about but really has no value. I still do it, but it has no value. And then, of course, blood work, and then you could potentially do more invasive testing, like a tap of the shunt reservoir, or monitoring of ICP if you're really unsure whether the shunt is working or not. So complications of shunt implantation that could lead to children coming to the emergency department, the ICU, the ward, include mechanical malfunction, and that could be obstruction and disconnection. And then also infections, functional failure, such as over-drainage or under-drainage in the setting of a working shunt. And with that comes a special syndrome that you may have heard of, slit ventricle syndrome, which I won't talk about too much. And then, of course, there's other complications that happen more acutely, intracerebral hemorrhage, interventricular hemorrhage, or abdominal complications. So mechanical failures, it's, again, like most of these complications, the rates are highest in the first few months after the shunt is implanted, and then the rates of complications go down over time. So mechanical failure, so breakages, disconnections, kinking, blockages, they're maximal in the first few months, first few years actually, but they tend to decrease over time. It's about 25 to 40% by year 2 or so, and then 5% per year. So a high number of children with shunts implanted, virtually all of them, will require some sort of shunt revision operation at some point in their lives. And early reasons for this are debris in the catheter, an intraventricular hemorrhage that blocks the shunt, clot in the catheter. And late causes for this are, for instance, ingrowth of the choroid plexus into the ventricular catheter, which happens fairly commonly. Ependymal scarring around the catheter that blocks it, an immune reaction to the catheter, which we've seen a few times, and occasionally we've had to order custom-made catheters that are non-silicone based, and then other causes of mechanical failure. And that's okay. And then shunt disconnection or fracture. It's commonest at the valve, and it's significantly higher in children than it is in adults, mostly because they move their heads a lot more and just their anatomy is not so well developed. Their heads are smaller, and as a result, the tubing that's able to kink and block and fracture is just much more vulnerable in children than it is in adults. And then potentially there could be shunt migration either out of the ventricle or out of the peritoneum. And of course, I guess you can have improper placement of the shunt, and that usually is identified in the early post-op period and something that we can fix very, very easily. And then skin problems that can arise as well. So this is one example of a shunt that is fractured. Here on the right, this is the end that's going into the belly. And you see there's a disconnection between the tip at the ribs here and the end here that is entering into the peritoneum. So this would be a fractured shunt. And say you have a child that comes in with 1, 2, 3, 4, 5 ventricular catheters, and they come in with symptoms of shunt failure. It becomes exponentially more and more difficult to investigate these children and try and figure out where exactly the problem is and how to fix it. But it is a scenario that unfortunately we do see occasionally. These are other mechanical complications that can arise. So this is a ventricular catheter that is not in the correct position. It's not sure where it's going, but it's certainly not in the ventricle where it should be up here. This is a pseudocyst that's formed around the shunt tubing, and often that happens in the setting of an infection. And this is a little pseudomeningocele that happened around the valve, which is very common in little children because their tissues are just so fragile that they can form these pseudomeningoceles, which most commonly are self-limiting. These are more of the functional problems that can happen with shunts. So this is a shunt that's inserted, and it's overdraining. So this is a child who would be expected to, for instance, have symptoms when they're more upright or after being upright for a long time that get better when they're supine or rest for a period of time. And you see because it's draining, the brain has sunk inwards, and you have collections of subdural fluid bilaterally. It's very typical of an overdraining scenario, and that's a situation where you may want to change the valve, put it to a higher pressure, or put a programmable valve in place. And shunt infections are one thing that we really struggle with. So the rates of shunt infection have gone down significantly over time, largely thanks to a protocol that was developed here by Jim Drake and Jim Rutka, and disseminated through the Hydrocephalus Research Network, which is a North America-wide organization. But shunt infections used to be about 15% or so, and they've gone down significantly over the last few decades to about 4 to 8%. It's still a significant number, but 1 in 20 shunts get infected. An infection alone, aside from the lengthy hospital stay in the intensive care unit, in the hospital, infections alone are associated or they're an independent risk factor for subsequent cognitive decline in adulthood and children. So it's something that you really want to avoid when placing a shunt, and it's an area of ongoing interest in the pediatric neurosurgery community. So about 4 to 8% occur, but they don't always occur at the same time. Or it's not invariable throughout the lifetime of the shunt. Infections really only occur in the first few months. So if a child had a shunt put in 2 years ago and comes in with a fever, comes in with sepsis, it's extremely, extremely unlikely that the shunt is the primary site of infection. I mean, it could be secondarily infected, I suppose, but it's extremely unlikely. So risk of shunt infection is really in the first 3 months is when it has a chance of getting infected. And then all the tissues scar, they epithelialize, and it becomes extremely, extremely unusual to have a shunt infection beyond 6 months or a year as the primary focus of infection. The pathogenesis is usually staph epi, as you know, but you can have all kinds of infections depending on the age of the child and depending on the vulnerability of the child. But it is something that really needs to be improved. Late shunt infections are really extremely uncommon, and they usually have some sort of secondary cause. Erosion through the bowel and an abdominal infection that seeds up the shunt is one reason, or secondarily inoculation of the shunt from another primary infection elsewhere. So those are the most common complications of shunting. I hope I talked a little bit about why shunts are important, but also why they are suboptimal devices that need a lot of care and attention and a little bit of understanding. And I'll be around a little bit later to answer questions, and I'd be happy to take some now.
So I was commenting on a colleague of mine that actually got a little bit intimidated when I talked to the ICU. And I probably shouldn't, because I think we have a nice collaborative relationship. I work upstairs on the 7th floor for most of my time. I also spend a lot of time with a complex care population for which critical care is a very important part of their lives. So I'm going to talk about care of children with medical complexity. And the first thing I should say is I welcome discussion. So feel free to, the most important thing I want you to say at the end of my talk is yes, but, right? So of the things that I say, I really do welcome. Am I supposed to press a button, by the way? Green. Okay. About any contrary opinions about what I'm saying, because I think it's important in our thinking about this population. So I'm going to talk about three things. I'm going to start with a little bit of a history lesson around, and I'm trying to contextualize the 50th anniversary of your esteemed department in the context of child health in general, and talk specifically about challenges in caring for kids with complex health issues, and end by speaking about what I think are a few key fundamental things we can do to improve the lives of these children and their families. So, like all presentations, I try to begin with a case. This is a case that's not real. I made it up yesterday. We're going to call it Sally. She's a 3-year-old girl, ex-23-week premature infant, had a grade 4 intraventricular hemorrhage, and has developed spastic cerebral palsy. She has seizures. She coughs with feeds. She has failed to thrive. She's in a hospital. She has recurrent admissions to the critical care unit with one of three things: aspiration events requiring respiratory support, status epilepticus, or sepsis. Please raise your hand if you've seen Sally before. Okay, in the 100th hallway or other parts of the ICU. Okay, so good. So this is the case I want to frame our discussion. So this is a figure of data from Canada looking at survival for a whole bunch of different congenital anomalies. And Sally doesn't have a congenital anomaly, but we could have drawn a similar figure for people like Sally. And I find this actually remarkable. And I titled this "The Times They Are Changing" because I'm a big Bob Dylan fan. Anyone know when Bob Dylan wrote the song "The Times They Are Changing"? I think it's around even 1963. So if I put it on this graph that's here, right? He won his Nobel Prize around here, and he stopped writing good music around here. So the amazing thing when you look at this figure, which shows survival of congenital anomalies, congenital heart disease, Down syndrome, spina bifida, and other congenital anomalies, which you guys look after very, very frequently, is how much that change in their survivorship has happened in the last 10, 20 years. This is not the revolution in medical, surgical, technological advances, the kind of things you guys do so well in the ICU, is really something that we're seeing the ramifications of today. There are now more adults with cystic fibrosis, with Down syndrome, with congenital heart disease, with lots and lots and lots of other conditions that we used to consider fatal in early life than ever before. And a really illustrative example of this is an example like Sally. So Sally is an very premature infant. And this just shows numbers from the US over 2 decades. Just compares the 1980s and 1990s. And there are similar sorts of data in other conditions. And what you see here is what I call a good news, good news story. So the good news, and this could be, again, replicated in many, many, many conditions that we look after, and I think is one of the unbelievable successes of child health, is survivorship has increased. The white here is increased, which is babies who are born very premature who survive without any major sequelae. The black is also good news. So black is mortality has declined. But the pace at which the white bars are increasing is not the same as the pace at which the black is decreasing. So as a consequence, the middle of these bars, which is what we call survival with impairments, so intellectual disability, visual impairments, auditory impairments, has dramatically increased, tripled for this particular population of very low birth weight infants. So it's so 2 things this kind of shows. We have created all these things to improve survival, but we have not kept pace with in terms of our ability to actually create cures for the underlying conditions these children have. You know, CRISPR technology and all these really amazing emerging genetic technologies notwithstanding, there really are not many examples of things we've cured, but lots and lots of examples of diseases that we've been able to improve survival. And the second piece of it is a lot of the things that we do to have improved survival involve technological innovations that have sequelae with them. ECMO being an example of something we frequently see in the ICU. So when you think of child health writ large, epidemiologically, most kids are healthy. 80% of children have no chronic health issues. Their care is usually provided by regular health providers, and sometimes they end up in the ICU. There's still a substantial and important population of children who are previously healthy who end up in the ICU with an acute deterioration from an infectious disease or something of that, or trauma of some sort. But this is becoming more and more smaller in proportionality relative to the other group of children who are those who have special healthcare needs. So special healthcare needs is about 15% of children, and it's just a child who has a chronic condition, diabetes, asthma would be examples of those. But the group I'm going to focus on has been the particular one that we're seeing more and more of in recent years are kids I'm going to define as children with medical complexity, who not just have chronic issues, but have substantial complexity associated with those chronic issues. So who are these kids? This is one definitional framework for who we're talking about. They're children who have substantially increased needs related to health services. They're children who have chronic conditions, but not any chronic conditions, but chronic conditions that are severe, and or those that are associated with medical fragility. And what I mean by medical fragility is if I get influenza, I am in bed. I was actually just talking to Jackie, who went through this week. If I get a viral infection, I'm in bed for a couple of days. These patients, when they get viral infections, are intubated and in the ICU. They use a tremendous amount of health care. And by a tremendous amount of health care, I don't just mean how many dollars and cents are spent on their health care, but really delineating the idea that they need care in many different places by many different people over time. Care at Holland Bloorview, care at sick kids, care in community, care in the home, care at school. And they have functional limitations. Their conditions lead to some sort of impairment in their day-to-day function, and often they need assistance by some sort of technology device like all those that you discussed this morning in order to maximize their quality of life. But even taking a step back and thinking about this whole term complexity, do you guys use the term complexity clinically? This is a socially complex family. This is a medically complex family. No one uses it? Yes, it's a rhetorical question. Good. Thank you, Chris, for stating the obvious. So I just want to take a step back and actually define the term complexity, because I think we use the term loosely, and I think it's important to understand what the term means. And sometimes the easiest way to define something is to actually define the antithesis of it, or something that isn't complex. So like a good Canadian. How do you define being Canadian? It's not being American and liking healthcare, or something along those lines. So, and the way I like to sometimes think about complexity is actually differentiating complexity from complicated. What do I mean by that? A complicated system has lots of pieces associated with it, with lots of intricate relationships between those pieces. But they work in predictable ways. So a classic example is a smartphone. This is not a simple device. There are millions and millions of pieces in here. They're all related to each other. But when I press a button, 99% of the time, the phone turns on in a predictable sort of way. Another way of framing it, complicated systems are things we can create blueprints for. We can create a blueprint for putting a human in space. You or I may not be able to do it, but if we train hard enough and we work hard enough and we get the right team, we can put a human being in space, right? And in medicine, there's many examples of that. Transplants, right? You can create a blueprint for how to do transplant and replicate it in another center. A lot of what you do in the intensive care unit, I think, fits that paradigm very, very nicely. It can be reduced to evidence-based approaches, and the ways of improving outcomes in it are different than the ways of necessarily improving outcomes related to complex care. Another example for complexity. So complexity is a little bit different. Complex systems, like my iPhone, have many different parts and many different relationships between those parts. But the key difference is the interaction between the components, the relationships are not predictable, right? So that for me is the essence of complexity. Real world example, parenting. I'm a parent of teenage daughters. So when my children wake up in the morning and I say hello to them at the breakfast table, their response to me varies based on many, many, many different variables, right? And I can't predict that. I can do many, many things to try to create the best possible scenario for a good outcome, but there are so many other extraneous variables that are often beyond my control that make that very, very difficult. And I would argue in healthcare, we have had much of what I've described before in terms of the improvements in survival and outcomes have been related to success of complicated systems in healthcare. We need that. If I have crushing chest pain and I go across the street to the University Health Network, my outcome is dependent on things that are related to complicated care. The technical abilities of the cardiovascular specialist who's looking after me, access to high quality care rapidly, how quickly I can get into a cath lab or what have you. Things that can be reduced to a blueprint. But in complex care, it's sometimes very, very challenging. I think of things that I commonly think about in complex care, and that you guys commonly think about it related to patient care in complex care. Do we put a tracheostomy in a patient? Sometimes it's black and white, but sometimes it's not that clear what the benefits and harms are associated with it and what the response of the child and the family is to the decision that we made. That, for me, is the essence of complex care. And how are we doing in looking after patients who fit these kind of definitions? So although their numbers are very, very small, their impact is dramatic. So we did some research a number of years ago that looked in Ontario. Kids who met that definition I showed before were only about 0.6% of all Ontario children, but consume about 1/3 of all healthcare resources. They're much more likely, as you all know, to end up in intensive care settings. Bad things often happen to them, and it's thought that often bad things happen to them in terms of medical error, but actually related to things like care coordination. How good we are at actually conveying information, complex information about them from one provider to another. And a huge piece of this that is often ignored is the component of the family. These are the families, I'm going to be as frank as possible, that are most likely to be dissatisfied with care. And I often use the analogy of frequent flyer programs I'll explain this in a minute to why this happens. Why do airlines create frequent flyer programs? One, to retain passengers, and two, who are the most likely people to complain to the airlines? Is it someone like my child who flies once every 2-3 years? Do they care if they're delayed 2 or 3 hours? It's a novelty, right? But if you're flying to Ottawa 4 or 5 times a week, and every single time the flight is delayed 2 hours, you can't see your family, you're late, all of those sorts of things drive people insane. To be frank, this is what makes people yell at us as healthcare providers, right? The experience of we're currently going through processes that are challenging and suboptimal. And the parents are also more likely to have health issues themselves, including some data that even shows premature mortality in parents who are inadequately supported in caring for their children. So the impacts are quite dramatic. And our care when we look after these kids is often a small slice of everything that the families go through. And I think that's a really challenging thing. I find that challenging in my day-to-day practice. I have an episodic interaction with a family, limited in duration, related to one piece, and I do mainly inpatient care. So an inpatient admission to hospital, or in your context, in an ICU admission. But there are so many other things going on that we sometimes struggle a little bit to really understand. And I think families sometimes struggle in communicating with us together in helping us understand. So everything I've talked about now may make you feel like looking after children with complex health issues is a little bit like watering a collapsing tree, but that is not what I really intend to portray. And everything I'm going to say in the last 10 minutes of this talk is going to be about strategies that I think work to optimize care for these kids and their families. So I'm going to talk a little bit about conceptual models, a little bit about stuff going on in Ontario at the moment, and a couple of clinical pearls that I found helpful over the years in caring for these kids. So this is a model of chronic care that was created by a guy named Ed Wagner, totally focused on adults, that I think about all the time in my interaction with patients. The chronic care model, and this is widely cited, talks about what is different about care of patients with chronic health issues, whether you're seeing them in an intensive care unit or any other setting from other groups of patients. So the key piece of this is the bottom of this figure. And again, I'm going to use the example I said before of me presenting with chest pain to an emergency department, a very acute care issue. The success of that outcome is predicated almost completely on the healthcare system, right? So what do I mean by that? Whether I'm a good or a bad patient, my acute care outcome in that scenario doesn't matter. And I'm using the word good and bad in quotations. What matters is, again, the technical capabilities of the people looking after me, the quality of the care that I'm receiving, and those sorts of things. But in chronic disease, I can be the greatest clinician in the world. But if I don't have an active and engaged partner leading care together with me, I'm not going to be a successful clinician. So think someone who manages, I'm going to use an example, a patient with diabetes, right? You can give the best evidence-based guidelines to the patient, but if for whatever reasons, poverty, housing instability, health literacy, or simply because you don't have a good relationship with that patient, they're not partnering with you, the patient will have suboptimal outcomes, right? That, for me, is the cardinal difference between looking after a patient with chronic health issues and looking after a patient with very, very self-limited acute care health issues. Your success will only work as a clinician or as a healthcare team if you have productive interactions between your team and an informed, activated patient. And everything else in the chronic care models, you need a healthcare system. You can't do this without decision support, information systems, Epic, I'm just joking. But you can't do this without a community and a healthcare system. But as clinicians, the cardinal piece of this is our interrelationship with patients and families. We have launched in Ontario an initiative focused on children with medical complexity to improve care for them that has created teams across the province focused on integrated and coordinated care. You may not see a ton of this in the ICU other than the care plans that sometimes accompany these kids. But just so you know that in the background, there is a strategy focused on these kids. We estimate there's about 6,000 of these children and youth across Ontario using a definition I'll show in a minute. We are gradually trying to develop an approach that will have a standardized team across the province. So every child in Ontario, hopefully in the next 5-10 years, will have something like the complex care program that some of you may be familiar with at SickKids. And the definitions, it's similar to what I showed before with an emphasis on technology dependence. And that was purposely created so that we had a high threshold so we can serve as many kids as possible. And these are freely available online. These we use as our inclusion criteria for our program. So if you ever put an ARMS referral to our program, it basically outlines these criteria. And so far there's been pretty rapid proliferation across the province. There are 4 tertiary care centers that now have formalized these criteria. And a cool thing that we're doing is we're actually partnering with a lot of community centers. So complex care programs are actually not necessarily nested in tertiary care. with a goal being that every child in Ontario will have access to complex care within 100 kilometers of their home. You can imagine if you're a family from Sudbury who sees 10 specialists in Toronto, you don't need an 11th specialist to see you. What you need is better communication with a team in Sudbury so that you don't have to come to Toronto for the 11th time to be told your sodium's normal by a nephrologist, no change to the clinical plan. We'll see you in 6 months or something along those lines. Not to pick on nephrologists or anything, but just using that as an example. I'm going to just move to another thing that I think is really important that we've done a lot of. So I talked briefly about care plans. I have memories in my not so distant past as a trainee. In the days we had paper charts in this hospital, and you guys were just getting into. You guys, the PSU was the first one to have anything electronic.
Yeah, last century we had a but not.
Yeah. So I go. I'm gonna tell you a memory that I relate to audiences quite frequently. I'd be called to the emergency department at 3 o'clock in the morning to admit Sally, right? And it would be the parents' 5th visit to the emergency department that week. And we'd have the paper charts in those days. So I'd have volume 11 of 14 available to me, and it was a bunch of IVIG orders, seriously, or whatever. And you're trying to quickly get a history to do the admission. And I don't think this is that much better nowadays, by the way, with our fancy electronic health systems. Still getting the whole story. Imagine, especially kids who get transferred from other centers with inadequate documentation. And you tap Sally's mother on the shoulder at 3 o'clock in the morning. She hasn't slept in a week. Invariably, it's the mother. And you say, I'm sorry to bother you. I'm really sorry. Can you tell me? I just have to know that Sally having medication allergies. And this is what makes people yell at healthcare providers, right? The idea of telling your story over and over again, duplicative care, gaps in care, all of that are in much part related to the fact that our documentation systems are so much dependent on episodic documentation. We have an episode of care, I write my notes, Chris writes his note, anyone in the room writes their notes, and then it goes in some magic computer and someone digs it up if they need it. Again, I think that works well for many, many, many kids. And I don't want to say that episodic documentation isn't helpful. But after a while, patterns emerge, and a way of actually having summative documentation about a patient is way more useful than having an episodic piece of documentation. So Sherry Adams, the nurse practitioner in our program, has done some amazing work in developing these care plans. We're building them now into Epic, which is another source of consternation that I can talk about for 15 minutes, but I won't. But the key pieces in here that have been really helpful, medication reconciliation built into this. Another really nice thing is common presenting problems with suggested management. Sally, when she seizes, doesn't respond to phenobarbital, she responds to phenytoin or something along those lines. Even environmental things. I had a patient with MCD about a decade ago that I looked after that got very anxious every time she came. It's a fatty acid oxidation defect. And I got very anxious every time she was hospitalized, but the color purple relaxed her. No idea why, but I saw it, and I believed it. So we put in her care plan, find purple bed sheets when she comes in. So it can be even something as subtle as that. The names of all the providers, it's unbelievable. I don't know how your unit clerk finds everyone in the hospital all the time, but sometimes you have to find people outside the hospital, and that can be really challenging. So putting that in is really helpful as well. But sometimes, beyond creating these information systems, I actually think we can reduce communication to much simpler issues. And I'll use this as a last example of something that I think is a key thing that we do in complex care. I love the art of Rube Goldberg. Rube Goldberg was an artist in New York in the 1920s. Drew all these crazy contraptions of how we try to find crazy technological solutions to things that are actually rather simple, like wiping your mustache after you eat soup. It's easier sometimes just to pick up the handkerchief than to create a whole new contraption. So sometimes I think a little bit about just the simple discourse that we use in communicating with these families and what we can think about and what we can learn about ways of improving that. It's interesting, I know Francine Buchanan was here this morning. It's a major area of interest of hers. So I'll give just one real-world example. Sally, she's admitted to your ICU with seizures leading to aspiration pneumonia, and you're seeing her at the time of admission as a nurse, as a physician, or any healthcare provider. What do you want to talk about? Goals of care, seizures, feeding, parenting challenges, prognosis, all of the above? Okay, so I also want to talk about all of the above, and I apologize for the graphic imagery here. It's the only graphic image I'm going to show today. The challenge of this is how can you do all of this, right? And this is my day-to-day life, and I think the day-to-day life of any clinician who looks after these patients. Where's my social worker? Where's my feeding specialist? Where's my remuneration for those people who work in fee-for-service environments, which isn't relevant to our organization, but very relevant in other places. And so I have to say this because I'm presenting the ICU. Where's the peds admitting physician, right? Can someone else deal with this problem, right? All these other issues that I'm focused today on the critical care issues. Again, I don't discount the amazing work you all do. And I think this is a real thing. And I put this image up because I think this is what happens. We come in, I'm the cardiologist. I'm here to talk about the heart. I'm here to talk about the heart. I know you want to talk about something else, but go talk to. And this is how you end up with situations that families tell us all the time. The lung guy said it's not the lung. The heart woman told us it's not the heart. That never happens, right? So whose job is it? There's an alternate version, by the way, of this picture that I sometimes use, where the actual person draws the yellow line and then goes around the animal and then keeps on drawing. People just want to go ahead and do what their job is, right? So, and I think it ends up creating a situation like the old fable of the blind men or women. I use both genders because the vast majority of healthcare providers in child health are women nowadays for good reasons. And what ends up happening that this fable is everyone's holding a different part of this animal. The specialist is is pretty sure that they're holding the neck of a giraffe. You have pediatricians in the back, and they're pretty sure they're holding a snake. And I'm going to call you an episodist, which is you seeing patients in an important critical phase of their lives, is feeling another part of this animal's body and feeling like it's something a whale, and no one realizes there's an elephant in the room. So that's really, I think, what ends up happening when we get quickly bogged down into what we're walking into the room with our preconceived expertise and area of focus. So. And I think this translates into some tensions that we develop. And I think it's because we are very focused often on diagnostics, which is of important relevance, but sometimes I think is emphasized in this population over time. We focus on problem lists, which is challenging when you have a situation where problems aren't necessarily ones with solutions to them. And we often end up getting into discourse around issues of managing expectations. And I know this comes up quite frequently in my discourse with many of you around patient care. But I think ultimately all of us are in this business because we want to improve patient care, and we worry about what can I actually do to help these patients. So I have learned a lot from my colleagues in developmental pediatrics, an area I know nothing about, and I'm glad Andrew's in the room, about using other frameworks. There's a wonderful framework from something called the International Classification of Function. And in the interest of time, I'm not going to go into this. But if anyone wants to know more about this, just send me an email. I'm happy to send you some great articles, including this wonderful one from a colleague of mine, Peter Rosenbaum, about F words. I swear we should start talking this way. Just using some open-ended language around how to get into discussions about goals of care. Something you frequently do and you guys do very, very well. But thinking about ways of framing discussions, not necessarily around problems or diagnoses, but open-ended questions related to what key definitions of function are. Function is actually defined as the interaction of body structure, activities, and participation, all in the context of one's environment and personal factors. And these are actually questions that I have started to use more and more in my day-to-day practice. And lastly, I was asked to talk about care maps, and I saw that there was a poster from Sherry outside about care maps, so I just wanted to illustrate another thing that can be helpful in trying to get stories from families. So, I alluded to the issue that families struggle sometimes in repeatedly telling the stories over and over again. So one thing we've been trialing is actually getting families to diagrammatically show a picture of what their child's life is. So we asked them a very simple thing. Draw a picture of your child and all the people involved in their healthcare and how they relate to each other. A fairly open-ended exercise. And it's amazing what you can learn when you ask families to do something like that. And given in an ICU setting, they're there for very long periods of time, and even in ambulatory settings for very long periods of time, there are actually many opportunities to do something like this. And you can learn a lot. You can learn who all their specialists are, how they interact with each other, whether they interact with each other in meaningful ways. This is purposely not meant to be easy to read. But if a family gives you something like this, you're like, oh my God, you guys got a lot going on. And I actually think immediately strikes some empathy between them and healthcare providers in at least getting a smidge of understanding what their experience is. Sometimes they look like this, which, very, very different one. And again, this will give you some way of starting to explore goals of care. This is a family that identifies faith as important. This this is a family that identifies. Playing at the park is important. And once you start doing stuff like this, you can actually get into meaningful goal-oriented discussions. So I'm going to just use one last example that's illustrative of this, a term I don't like because I don't know what to make of it. Intractable seizures, common thing you see in charts. What does that mean? It's, I come back to the point. We all enter this business because we want to help people, but they have an intractable problem. So how am I actually helping them? If you actually get into goal-focused discussions, the goal can be fewer seizures. The goal can be just making them good enough that they can go to a summer camp, that their summer camp will accept them. And actually, then you can align treatment decisions along with family goals. If you can actually use concrete goals that are related to their level, to their functioning, not just their body structure functioning, but actually how they participate in communal life. So just use that, just an example of that. So I think I'll stop there because I've said a lot too much, and that actually isn't grammatically correct. But if anyone has any comments, please let me know. And my email's there, and I'm always happy to entertain questions or discussions offline. I'm on the 7th floor. My office is right outside Ward 7D. Thank you.
I have one question. One of our colleagues that's watching from Manitoba has a question around further discussion of the remote areas in Ontario, and are you still flying families in, being able to reach out, and what are your plans for expansion?
Okay, so within Complex Care Kids Ontario, so there's a few things. First of all, I think there's been very nice growth of the Ontario Telemedicine Network in recent years for both acute and chronic care in allowing patients to receive care closer to home. That's still a work in process. In terms of CCKO, the Complex Care Kids Ontario, we have purposely developed satellite clinics to minimize travel of people in remote areas. Are in the process. One of the satellite clinics is in Timmins, and we're in the process of developing a strategy for the north to include Sudbury, Thunder Bay, and Sault Ste. Marie as kind of northern hubs for these patients. And then working together with our partners to work with families who live in more remote areas than that. So it's kind of like a hub and spoke model where you have centers of excellence in communities closer to those in remote areas and really leveraging telehealth as much as possible. Thanks for the question. Please.
So you're aware.
So am I. Thank you.
No, my son's part of the complex care team at the cancer. That's his business. So I'm actually aware of that. But I know that there's a lot of families who live in the district in Ontario who have complex children and aren't really aware that this is available at centers close to them. So is there some way that this is being communicated? Because their kids are treated as sick kids and then they go home.
Yeah, so I probably sold the success of this. So we have in Ontario, I said there's about 6,000 kids who meet criteria, and at the moment, across all of those programs, there's probably about 700 children who are currently being enrolled. This strategy is 3 years old, so we're in year 3 of our 5-year funding envelope, and it's just been renewed. So the idea is to expand this over time. There are regions of the province where there is literally no complex care services. Southwest Ontario is still a bit of an area with a lack of service. So there is an issue of geographic inequity. I think this also comes back to the question about rurality that we're working on. I presume that's not all that different from where critical care was in its earlier days, right? Like getting to issues of standardization is, I think, not unique to complex care, but you're absolutely right. It should be a very important goal of what we do over the next 5-10 years. Thank you.
Our next speaker is Carrie Boyer, and she's been a nurse at Sick Kids for 17 years and has been our transition coordinator for complex patients out of the ICU for the last 2 years. So she's going to talk to us about that today.
Hi, everybody. We heard for all these patients, they're dependent on so many technologies, and they've been in the hospital most times, like from a couple of weeks to months, sometimes even more than a year. But at the end, there's a light, and I get to give the good news to families. It's time to prepare them to take their babies home, babies' children home. However, sometimes the transition discharge could be a scary word for families because they've been ups and downs, scary moments for families, moving between different ICU and different units. So it's taking that sick baby because they've seen the worst moments. It's really scary for them to take that baby and take care of everything at home settings. After a while, we might think that patients are stable for ICU settings, but we don't know how parents feel about that, like taking care of that baby patient at home. They have to learn healthcare professional skills, and we need to support families in this process, support them with all their equipment, supplies, teaching, community services. So we'll talk about this. So our role of transitional care coordinators, we are registered nurses. We cover inpatient units. We work with the programs to transition complex patients from hospital to community or other institutions. We are part of patient access and flow to create capacity within the units and inpatient programs. Most of the complex patients, we transition them to community, home, and also Blue programs. We'll talk about the Blue programs a bit later. We are here to support and educate patients and families on their journey to bring their children home, inform families about all the available resources, funding, and services in the community. So patients we are involved with are patients with what we call complex discharge needs. The patient could be very sick, but closer to discharge time, sometimes they do very well and they don't have too many complex discharge needs. However, sometimes it could be only with home oxygen, suctioning, or G-tube, but the child could be so complex, depending on what else is going on with the family. We need to support them accordingly. So most of the patients we are involved with are trach patients, trach vent patients, patients who require BiPAP, CPAP, nasal stents, and NP tubes, patients who require home oxygen, suctioning, saturation monitoring, patients with the G-tube, GJ-tube feeding, in addition to the trach vent home oxygen patients. Also patients with the prolonged hospitalization, deconditioning with the rehab needs, trauma patients, cardiac arrest patients with neurological injury with the rehab needs. We are also involved with the out-of-province patients and non-OHIP patients because they don't qualify for home care services. We are also involved with the patients without residency to be discharged. Some families, they don't even have a home, so they may stay in shelter, or they might be in transition between the homes. They might be newcomers to Toronto, so they don't have any location to discharge. Even family learns the care, and most time they need a lot of support, but they don't have a destination to discharge the patient. We are also involved with the interim federal health program patients, refugee claimants, and RON residents, newcomers to Canada. We also transfer patients with the air ambulance transfer within Ontario and within Canada. So preparing for discharge and transition, when we meet with families, I always ask that, can you tell me how your baby, how your child is doing? And I might hear from the teams, they're ready to go, they're ready to leave, but I want to hear from the families what they understand, where they are. I don't want to tell them, oh, okay, you're going to move your child. That's not good. That's going to be very scary for families. And I'm going to hear from them that they're happy how their child is doing. so we can plan the next transition. Part of this transition is that for parents, family members, to learn how to take care of their child. In the hospital settings, especially in ICU settings and hospital settings, still that patient is assigned to a full team. They have a nurse, they have RT, dietitian, OT, PT, social work, everybody they need. We can call people with the one phone call, and we have this nice wall unit, oxygen, suction machine, humidity, everything comes from the wall. However, when we place that baby to home settings, everything will be absolutely different. So we need to work with the families and with available funding resources, how to get all this equipment and supplies. With the learning needs, most times like we assume families to be here 24 hours, take care of that sick child, but most times we need to consider family as a whole unit, what else is going on in their lives. They have other children, life does not stop because we have one sick patient in the hospital. They have a responsibility to take care of their other children. We have to work with them to make it happen, make a teaching, learning schedule with the family, dedicate that times for the teaching, to make sure that that family shows up for 2 hours of teaching session here or later at Bloorview. The teams are also prepared. We respect their time, and we also respect our time. We also discuss about all the required equipment and supplies and how to get those. Available funding resources, home and community services. Also, our great partners, Holland Bloorview Kids Rehab Hospital programs, as well as respite services available for those families. So, learning how to take care of these complex patients. For most of the patients depend on the treatment. There's a requirement to fully train 2 adults, 2 caregivers to take care of that child around the clock, in addition to shift nursing. That's 2 is the minimum requirement. Any additional family members, friends, welcome to train. With this infant and child CPR class is part of this training. In addition to 2 fully trained caregivers, there's a support from the CCAC. Now they are called home and community services. 40 hours is their usual time. Usually, we advocate for like 7 nights coverage, but most regions, like our families don't get that. Once in a while, like one family might get like full night coverage, 7 nights coverage, but that's getting less and less. There's still work to improve this process to advocate for those families. I think we discussed a bit earlier, within that 40 hours, sometimes if the nurse is sick or if they decide not to show up, there's no coverage. Family has to stay awake 24 hours, 48 hours, or even longer to take care of that child. Because for airway patients at home, they can't just put the baby to sleep and they can go back to sleep. They have to stay awake and watch that child around the clock. So if their nurse doesn't show up or if they quit, so in that transition, it's a family's responsibility to take care of the patient. So for this training, treatment training, it takes approximately 6 to 8 weeks minimum, because we want families to learn the theory part as well as hands-on practice from the beginning of the training until they are fully independent. They can take care of the patient, problem solve, and deal with the emergencies. Minimum, from our experience, like minimum 6 to 8 weeks. It could be even longer if there's a language barrier, if you have to use interpreter, or if the commuting for parents to come to the hospital is not available. If there's any additional family members to train, it could be even longer. So because because of all these reasons, like we transitioned them to Blue Reef Kids Rehab Hospital to transition home, because here at Sick Kids, like the level of care they're receiving is quite high, but their home settings, like they're not at the same level. So we gently transition them from hospital Sick Kids to Blue Reef to home settings. It will give them more time and flexibility to do hands-on care, practice more, even though sometimes they completed the theory part. It's a skill that we want them to develop and be independent. It takes time for different people, especially when you think about adult learning principles, information they receive, they can't recall easily. For all those skills, we teach them, not only for the sake of teaching, but they will use that at home settings. It's different to take care of a patient, do the simple thing, taking care of G-tube side or trach change or suctioning trach. It's different to do it in the hospital settings. If something goes wrong, press the button, somebody else will come with the full support. At home settings or unexpected, if it's like one of the family runs or trips, and if the trach comes out, the family has to have the skills to learn how to problem solve it, and there's nobody else. You are the only adult taking care of that child. So our role is make sure that we work with the families to give them all the skills, information, and knowledge to learn all those skills to safely take care of that child, and make sure after that all that hard work, the child survived the critical care stay, complex hospital stay, and make sure they stay safe in the community and continue to develop and thrive. So for the equipment and supplies, we talked about all the complexities and devices and the services. For the equipment and supplies, most times like, they need for trach patients, trach band patients, for example, they have to go home with a home oxygen saturation monitor, at least 2 portable suction machines just in case if one fails. They need high output compressor for extra humidity, and trach and suction supplies. Sometimes they may need a heated high humidity air roll, which is super expensive and it's not covered by Ministry of Health. And we need to advocate further for the coverage. It's on our to-do list. Most times they also need a home oxygen, G-tube, GJ-tube feeding and supplies, and portable pump. Because wherever the child goes, they have to carry all these equipments except the high output compressor and air roll. If their regular stroller or seating needs to be assessed, and they need for infants they need a special stroller, and for bigger kids they need a specialized wheelchairs. There's the ADP assistive devices funding for that, but in addition to the cost for all this, for seating costs, sometimes it could be as high as $10,000, and the ministry covers 75%. Remaining is family's responsibility. In addition to the psychological impact for the families, there's a huge financial impact as well. Even though some funds available from the Ministry of Health, it's still not enough. So we need to advocate to Ministry of Health for, which I believe that it should be 100% coverage. If they're saying that the child cannot live without these equipment, the families should not be paying, but it should be paid by the ministry. So available funding for these patients and families. On the list, it looks like I tried to summarize the major funding availabilities. It looks like a long list, but not all of them are available to everybody. So the first one is Assistive Devices Program from Ministry of Health and Long-Term Care. So how it works is if the child needs a trach band, home oxygen suction machine, G-tube, GJ-tube. So for most families who work, even one parent works, if they're making some income, they cover 75% of the cost. the 25% is family's responsibility. And most times, family has to, at the closer to discharge time, family has to go to the vendor, buy their feeding pump, they provide a Visa card number for home oxygen, trach supplies, and then wait for their small amount of check from ministry. And when you think about social determinants of health, most of the families, they're not in a great financial shape to provide this Visa card. They can, for the treatment patients, initial cost for the discharge, it's around minimum $2,500 for equipment and supplies. Plus, if they for smaller incomes and for patients who need a feeding tube, G-tube, GJ-tube, they have additional for pump and supplies, $1,200, $1,300 upfront cost. So it easily maxes out to $4,000 just for the equipment and supplies. In addition to that, they have most of these babies, patients, they cannot tolerate regular breast milk, they cannot breastfeed, they are on specialized formula. Those specialized formulas, even with the OHIP Plus coverage, they're not covered. Families are around from $700 to $900 a month extra formula expenses. You have to feed your baby. They scramble to find that money, and plus the wheelchair cost, everything adds up. And some of medications may not be covered. All those are costs, and plus the frequent clinic appointments, coming to hospital, taking time off from work. Those are all the extra strains for the families. The second one on the list is assistance to children with severe disabilities. So this is a bit tricky. It's additional funding. Oops. How do I go back? So assistance to children with severe disabilities. It's additional funding from the Ministry of Health and Long-Term Care, but it goes with the baby's medical needs, diagnosis, and also family's income. So for a family of four, mom, dad, two children up to 18 years of age, if the family is making gross income before tax, if their income is $62,000, if it's less than that, they may qualify for some funding. If it's more than that, they would not qualify for anything. So in addition to ADP funding for families making less than that, they can receive funding for trach patients, for example. They can receive around $460 a month. So it's most of our families that they won't qualify. So the next one on the list is sick patient amenities funding. From the hospital, we have a limited amount of funds available, but there's a cap per patient. We need to explore all the other options before we access those funds. And our social worker colleagues are a great resource to guide us. 2,000 per year, right? Yes. Fiscal, for sure. Considering that so most of these patients stay in the hospital settings for months and months, and most times that they max that amount with the parking, some meal tickets, and with additional help. And at the time of discharge, nothing left to help the family with this cost. So the next one is enhanced respite funding. Later on, when they are discharged home from CCC, community at home healthcare, they can start this funding. They cannot start it before the discharge. So for treatment patients, they will qualify most times, but we believe they will qualify for this funding. So families will receive $3,500 per year. It's funding is approved, so they can use that funding to hire additional caregivers, nursing. But it's up to the family to find which nurse to hire. It's a process. The funding is available, but the family has to manage and hire their healthcare professionals. The next one is special services at home. Still, again, they have to apply for funding for medically complex patients. Once the funding is approved, they can use that special services at home funding for basic care, respite care as well. There are some charities: President Choice Children's Charity, Jennifer Ashley Children's Charity, Easter Seals, and David Foster Funds. And they're also helping our families. Do you guys have any questions? For sure. Question period? Definitely. I try to squeeze all the information because all these things I can't talk about it all day. But so in addition to trained caregivers and families, these patients they get help the nursing, shift nursing from the community and home care services, previously called CCAC. You can also hear like LIN, Local Health Integration Network. They are how they describe themselves is that they are the care provider in the community. In the hospital settings, we provide inpatient care. In the community, their role is supposed to be providing full care to those complex patients, pediatric and adults. However, from the experience what we hear, it's the service they provide is quite limited. For example, Joanne, you mentioned that the challenges with the G-tube even for continuous feeds, those patients most times, they don't qualify for their services. They're very selective, and from the pace that how we are treating these patients, how we are discharging them to community, they're not at the same level. They're just keep practicing the same thing. They're providing some of the nursing services, but I think for pediatric complex patients, we need to advocate more for our patients for better coverage, and also expand their criteria to provide the coverage for our patients. Because most times, these babies' cares around the clock. They cannot, families cannot just start feeds, go back to sleep at 3 a.m. at night. They do aspirate incidents happen in the community. So for the trach patients, we mentioned that they like to provide 40 hours per week, and family can choose to use either daytime, weekdays, weekends. But at the beginning, we strongly recommend them to start using that at night to cover at least 5-6 nights, so they can hopefully catch up some sleep. In the morning, they can start fresh to take over that baby's care. For shift nursing, instead of shift nursing, once the family is discharged home, they know how system works, how shift nursing works. There's funding option available from CCAC, and they can request switch to receiving the funding from the CCAC. They can hire their own nurses, but the problem is there's a lack of pediatric trained nurses in the community. Their skill sets. Most times before the discharge here at SickKids, and I believe at Globeview, reviewing those nurses to get to know our patients, meet the family, and also top up their training, and also give handover for our patients' airways and overall care. This cost is covered by OHIP. There's no cost to families. And in addition to shift nursing, they can also provide school nursing. The trach band patients like Cristiano, they can receive shift nursing at night. When the child starts school, they can also provide school nursing the time that child is going to school. Also, they can provide rapid response nursing if that child gets severe and visits during daytime. PT, OT, dietitian, and personal support worker as well. You guys have any questions about CCAC services? So from the SickKids ICU level until they go home, you might say the child is ready, we give you all the training, you're technically trained. However, if the family, most times, if the family doesn't feel comfortable with taking the patient home, we refer them to Globeview programs. We have a great partnership with the Globeview Hospital. They have 3 different programs: complex care program for trach band training, transition home, and ongoing rehabilitation. for brain injury rehab team program for neurological rehabilitation, a specialized ortho developmental rehab program for severe condition and musculoskeletal rehabilitation, and also respite care for medically complex patients. And most of our treatment patients will qualify for respite services. So for transition to home program, we send the initial referral. Medical readiness is assessed between the ICU and complex care. We do the intake meeting to give additional medical updates. We send our families for a tour. We fax handover tool with additional medical notes. We arrange transport with our nurse, RT, and one parent going. We do nursing handover and send a discharge summary medication list in the morning of transfer. And the parents are required to stay on, especially on the day of admission, and also be around for the care. Any questions?
So our next speakers are Drs. Hoffman and Chang. Dr. Hoffman is a developmental pediatrician from Bloorview, and Dr. Chang is a pediatric respirologist that works jointly at Sick Kids and also at Bloorview, that are going to talk to us more about continuing clinical illness outside of the ICU. We have one right here.
Thank you so much for inviting us to be a part of the symposium today. As you've heard, I'm Andrew Hoffman. I'm a developmental pediatrician, and Jackie is a pediatric respirologist. And we work together on the complex continuing care inpatient unit at Holland Bloorview. No conflict of interest. And the objectives for today is really to review the services offered by Holland Bloorview, to review the admission criteria for our inpatient unit, and then to describe one of the programs, one of our pathways, the long-term ventilation discharge pathway. So we realize that many people have probably heard of Holland Bloorview, but not everyone has necessarily come to visit us. And so we wanted to tell you a bit about the services that we offer and show you a little bit about our site. So this is our building. We're a freestanding pediatric rehabilitation hospital. We're at Bayview in Eglinton. So we're across the valley from Sunnybrook and behind the CNIB off of Bayview. Our hospital and grounds are all fully accessible, and we are situated on the side of a beautiful ravine. In addition to the medical services that we also offer camps and respite programs. And really the hospital, in addition to the medical services, really is a hub for participation and inclusion and working on independence for children with all types of special needs. There are music programs, there are art programs, gym programs, life skill programs, so you name it and we have it. There's also an on-site school, an IET school, the Integrated Education and Therapy program. And the nice thing about the school is that it does allow kids from the community to come in for sort of this specialized school program, but it also is open to our inpatients. So during the school year, our school-aged clients will go down and will be able to attend school during their admission at Bloorview. In addition, we really do feel like our hospital has an important role in terms of advocacy and ongoing education. Not everyone knows Bloorview also has a full research institute, so it's called the Bloorview Research Institute. And we're also fully affiliated with the University of Toronto. So in terms of the clinical services, so we serve about 7,500 families a year. We are both an inpatient and an outpatient hospital, which is quite unusual for pediatric rehab centers in Ontario. When we look at the outpatient services, so we are the regional rehab center for children in the Toronto area who need to access rehab services. We also are a provincial resource for some of our specialized clinics. And so that would include things like neuromuscular clinics, spinal bifida clinics, and brain injury clinics. On the inpatient side, as Perry Hen has alluded to, we really have 3 inpatient units. The first is the brain injury rehab team, and that supports, as the name would suggest, children who have had a brain injury. We also have the specialized orthopedic and developmental rehabilitation unit, or the SODR unit. And that unit supports children who, again, as the name suggests, have had orthopedic procedures, so hip surgeries, tendon lengthening, spinal fusion. They also support children who have spinal cord injury, as well as children who are severely deconditioned. So among the kids that would be served in the ICU, they might support children after they've had a transplant. And then the third unit is the complex continuing care unit, and that's where we work. And so we really are focused on transitioning children with a high degree of medical complexity from hospital to the community. So each of the three units are structured quite similarly. So this is the nursing station on CCC. Each of the units also has an activity in a dining lounge where families will come for communal meals. They also have a therapeutic rec, and it's also just a place for people to hang out in our hospital. And then in terms of the rooms, most of our rooms are single or double occupancy rooms, but we do have on CCC high observation rooms where the nursing station is actually in the room itself, so that we can provide constant eyes-on care. So in terms of the CCC unit, we just wanted to take a moment and talk a little bit about then and now. So people who may have known the CCC unit in the past, it has changed a lot over the past many years. So historically, the hospital initially was supporting primarily individuals with DMD who were trait invented, where there really were no community supports to be able to meet the needs of somebody with that degree of medical complexity in the community, and where institutionalization really was the expectation or the standard. Over time, the unit changed and really became known as a place where children would be referred or would be sent if there was identified difficulties in transitioning them to the community. And that may be because of their medical complexity, but it may have also had to do with a lot of psychosocial complexity. So individuals who had CAS involvement or where parents identified that they either couldn't or wouldn't take their child home for various reasons. And so despite the fact that we were never formally a long-term care unit, functionally, that's what we were. And so when we look at sort of data in 2010, the average length of stay in a unit was 6.5 years, and that ranged from 4 months to 18 years. When we looked, our population was largely individuals who were invasively ventilated, so 70%. 30% of our unit were adults. In fact, we were a pediatric facility. There are issues with that. And the other important thing is when we look back, in 2010, there were no admissions and no discharges. So people really didn't come and didn't leave. People essentially lived there consistently, and there really was no movement through the unit. And then when we look at the population that we were serving, they really had consultative therapy needs only because they were individuals who really sort of lived, they were medically stable because they were with us, and they really needed consultation from therapists, but really had no active therapy goals. Fast forward to today, and things have changed quite dramatically, and we're serving a very different population now. So some people in the audience may recognize this young man, I'm not sure. He came through the ICU at SickKids, so he has transverse myelitis, he's trait invented, but you can see that he's actually receiving active rehab by some of our therapists on a treadmill. And so when he came to us, his goals were for active rehabilitation in addition to a transition to home and community. So over the past 5 years, there has been this dramatic shift in the mandate of our unit, with really a focus on transitioning children with medical complexity from hospital to community. And over this time, and particularly sort of through work in the past year, really with alignment of the Bloorview as well as the SickKids KIP, a number of people who are sort of here in the room today have really worked to help us to clarify the admission criteria for the unit, but then also to help to facilitate transition from SickKids or from acute care to our unit at Holland Bloorview. So when we look at our admission criteria, we are a pediatric rehab hospital, and so individuals need to be under 19 years of age, and that is a year older than sort of what's allowed at SickKids. The other piece is that a discharge destination has to have been identified. So Bloorview is no longer the destination. We are really just a part of the journey as they transition to the community. And then the third part of our criteria is that the child has to meet the definition of medical complexity. And we use the same definition that Dr. Cohen was speaking about earlier on in the day, where children have to have a combination of technology dependence, medical fragility, complexity, and chronicity. And so this is the definitions that's used by Complex Care at SickKids as well as by CCKO that was spoken about earlier. So in terms of common reasons why a child might come to Bloorview rather than transitioning directly home from acute care, is that they would sort of meet those initial definitions, but that they would also be a child who would benefit from habilitation and rehabilitation, and or the child and the family requires teaching and training regarding their medical management and rehabilitation, and or the child and family requires support with acclimatization to new medical technology, and or the child and the family would benefit from a stepwise reintegration to home and the community. So it's not that they're in hospital and then they're home, but rather sort of this intermediate step between acute care and the community. I think it is important to sort of take a moment right now just to sort of pause and to talk about some of our criteria and really sort of how we determine readiness for when a child comes to Blue Review. We've talked a lot about some of the amazing services and the supports and the resources that we have at Blue Review, but we also do have some limitations. So because we are a freestanding pediatric rehabilitation hospital, we don't have many of the services that one might expect from an acute care hospital. So when children come to us, they really do need to be medically stable. And the reason why, when we sort of look at the services that are offered, so we don't have a physician in-house after 5. We don't have, despite the fact we have a unit of trach vented individuals, we don't have an RT after 11. We have imaging capabilities with X-ray during daytime hours, Tuesdays through Fridays, but really have no other imaging modalities, and really have nothing evenings and weekends. And when we look at blood work, we have our lab that we use at Sunnybrook. So blood work gets picked up once a day and is taken over to Sunnybrook. And so although we can order stat labs functionally, we can't really get stat labs. So there are some limitations to the services that we're offering. We are working towards a 24/7 RT model. We are working towards getting an iStat machine, but we're not quite there yet. So when we're sort of looking at the resources that we have, we do need to make sure that children are safe before they're coming to us. So when we sort of look at sort of the then and the now again, this is more a reflection of the now. So when we look back in 2010, we said that there was no referrals and no new admissions, whereas between September 2016 and 2017, we had 29 referrals, of which 27 did come through Blue Review. And the 29 referrals were specific to sick kids, but we did receive referrals from the provincial resource, so from other places in the province. And when we look at the referrals from sick kids, they're coming from a variety of different areas, so pediatrics, critical care, cardiology, the NICU, and then surgery and trauma. And at the time that the slide was made, 17 had transitioned to the community, but we're so pleased to say that at this point in time, all 27 from this original slide have in fact since transitioned to the community. So this is a successful program in terms of how we are moving people from acute care to the community. And with sort of the changes in our referral patterns, as such, has also been a significant change in the demographics of the population and the needs of the population that we're serving. So when we look now, in the past, we had consultative therapy needs only. Now 100% of the children that are rotating through our unit have active rehabilitation needs and active therapy goals. When we look, more than 60% have more than 2 medical technologies, and over 80% have complex feeding and nutrition issues. Over 50% have a tracheostomy, and over 50% are infants under the age of 1, which again, when you consider that not long ago, 30% of our unit were adults. So this is sort of a huge shift in terms of the population who we're serving. So we have to send the presentation as 2 parts because it's too much.
So as Andrea alluded to, there's been a significant change in the unit's admission criteria and the expansion of that criteria. And so we've worked hard in collaboration with our acute care partners, and namely Sick Kids, to provide standardized transition pathways for particular targeted patient populations. And one of the first and most successful has been for children requiring tracheostomies and invasive ventilation. So the reason why that's the case is because it was identified that these children were spending an exorbitant amount of time in the ICU, as indicated earlier this morning, and oftentimes unnecessarily. So when we look at our LTV database data, we identified that from 2008 to 2013, the median length of stay in the ICU for these types of children was 195 days. And so in terms of looking at it from a healthcare utilization perspective, in addition to the overall well-being of the child and the family, that's suboptimal for sure. So several years ago, the discussion was first proposed to transition these children to Blue Review, not only to free up ICU beds, but also to provide a more developmentally appropriate environment for the child and their family, in addition to providing access to therapy and to caregiver training. In 2016, the new LTV discharge pathway was officially implemented, and it was informed by debriefs from patients, families, healthcare providers, some of whom are in this room, in addition to similar quality improvement initiatives in Colorado and in London, UK. The whole design process took about a year, and with various feedback from multiple divisions and across institutions as well. So as Dr. Min mentioned this morning, this is the family-friendly version of the LTV pathway. This is one part of the healthcare version of the LTV discharge pathway. And you're not meant to actually see all of the detail, but as identified earlier, it's structured in swim lanes, and it basically sets to operationalize specific tasks and designates it to specific individuals or specific healthcare providers, including family caregivers. And the whole goal of it really was to improve efficiency, maximize family engagement, and also to increase patient safety. So this is the first of 4 timelines in the pathway, which is designated the pre-tracheostomy section. And the summary of this is on the right side. And essentially, it really is, the primary goal is to identify that there is a child that does require long-term ventilation. And usually that identification happens in an intensive care setting. When that happens, the respirology consult team is involved, and then thereafter the LTV or long-term ventilation team. So Joanna, our nurse practitioner, and Faiza, our respiratory therapist, will come meet the family and go through what life is like with the child at home requiring invasive ventilation. Afterwards, there's a decision that the family makes in terms of pursuing this path, and then a tracheostomy is inserted. Ideally, afterwards, caregiver training is initiated. The second timeline or time frame is 1 to 2 weeks post-tracheostomy, and that's typically the time frame where they are transitioned or transferred to Bloor View. So in this time frame, really it's about ensuring that there's a stable airway so that the tract is well formed and the stoma looks good, that ENT has performed the first successful trach change. It's never too early to actually initiate discharge planning and caregiver education. And as Andrea alluded to, given the limitations of our institution, we really need to ensure that the patient is medically stable. From a respiratory perspective, that would be one, tolerating the home ventilator, which in Ontario is the Trilogy, ensuring that they have optimal gas exchange, so FiO2 requirements less than 40%, for example, and reasonable carbon dioxide levels, and then we're happy to accept them. The third phase is the 3 to 4 weeks post-tracheostomy. And this is where the Bloor View team really is quite involved in terms of reevaluating the patient and their needs. So that would be, reassessing their nutritional needs, their therapy goals or needs, equipment needs, in addition to the respiratory needs. So, we're more than happy and involved in evaluating their ventilation needs. And if we're able to, we will actually wean their ventilation. The large part of caregiver education is happening right now as well. And we use what Dr. Min had mentioned earlier, the kids vent tool, or it's now divided into the T tool, which is the tracheostomy portion, and then the ventilation piece. And so this was developed with feedback from various healthcare provider input that specialize in pediatric home ventilation across Canada, with further validation work in progress. And there's a number of different sort of topics that are involved in this tool, and it's really to standardize and ensure that all of the necessary skills and knowledge are completed for family caregivers in order to ensure that they can safely take care of their child at home. We've actually received some funding within this past year to perform a qualitative study to evaluate family caregivers' perceptions on their training and to evaluate their feelings on competency attainment. So that'll be interesting to find out what they actually think. So the last section is actually the 5 to 8 week post-tracheostomy timeline. So this is where ideally most things are being completed. So in terms of discharge planning and caregiver training, we have a graduated process of discharge whereby families actually acquire graduated levels of responsibility in terms of providing care for their child, depending on where they are in their training and their comfort level. When they've completely been signed off on all of their caregiver training and feel confident, then the next step would be a care by parent, where they move into the back hallway and then they assume responsibility for all cares for a 24 to 40-hour period. Once that is successful, the next step is an LOA, or leave of absence, where they take their child home with all of their equipment, and hopefully the community care nurses have been identified at that point, and they would be able to support them in the home as well. And that's really just sort of to practice what life will be like in the home and troubleshoot any issues that will arise, whether it be accessibility issues or space issues or whatnot. And then also to develop a relationship with their home care providers. So as part of this whole admission process, we also do monthly family team meetings with families and the home care providers, where we review all of the steps that are necessary for discharge and make sure we're actually following the timeline proposed for the expected discharge date that we set usually about a week after they come in. So a similar pathway is being developed for medical trachs alone that SickKids has been involved in. Unfortunately, despite our best efforts, multiple barriers to discharge still exist. And anecdotally, I would say the top three are lack of appropriately trained home care nursing. Two would be the financial or funding issues for families, and then third is usually some sort of housing situation that is not conducive to bringing their child home. I think it's also important to recognize that as much as we try to prepare families for what life is going to be like with their child at home, we can never fully prepare them to actually take care of a medically complex child. We can only do our best in that scenario. So despite us talking about this in a linear fashion, from SickKids Purview to home, it actually is more of a circular model, right? So we know that these patients are going to be followed up from an outpatient perspective at oftentimes both institutions, so Purview with either neuromuscular clinic or the spinal cord injury clinic or even CDE and orthotics, back at SickKids in either complex care or the long-term ventilation team, and then sometimes in the ICU when they're readmitted, unfortunately sometimes more frequently than we hope. But there are success stories, and this is why we do what we do, right? And it keeps us going. And so this is a young man that was in the intensive care unit about 2 years ago. Some of you may remember him. And I think he spent a significant amount of time there on dialysis. He was on a ventilator. He came to us for rehab and transition home, fully ventilator dependent. Upon discharge, we had completely weaned off his ventilation. He'd been decannulated, and he actually was able to independently walk out the door himself. So it's always nice to end off with a success story. So just want to acknowledge the amazing teams that we work with and ask if you have any questions for us. And I think the important thing to recognize is that there has to be a discharge destination. That discharge destination doesn't necessarily have to be the family home. but it should be recognized in advance and discussed in advance by the healthcare teams if one thinks that taking that child home to the family home will be a problem.
It's also that there has to be a recognition that this child is going to transition to the community. So we've had families that are committed to transitioning their child home, recognizing that they currently don't have appropriate housing. So we will, by knowing that in advance, we can start to help to advocate for some of those pieces. And in some cases, they don't have secure housing necessarily when they leave, but we've been able to connect them with a family member or a friend where they can stay while they're waiting for appropriate housing. We've written advocacy letters. So there is a recognition. So it's not necessarily that we're going to solve all of these issues, because often we can't, but that there is a commitment from the family that they are going to be transitioning to the community. In some cases, families have identified right off the start they actually aren't going to be able to take the child home, and they're looking for a group home option. So again, we know there can be a wait for that, and we don't want them necessarily waiting in acute care for that group home option to become available. But there has to be recognition and a discussion before they come to us that this is a child who we're looking for a placement in a group home, and that those applications are being initiated and that those conversations are being initiated.
Well, in that scenario, if there hasn't been any red flags that were noted in advance, then certainly we would have to call CAS and discuss, the next course of action for sure, because they can't reside at Worldview. We have called CAS in the past for various circumstances. They are right, but the only issue being that for a child with a tracheostomy and ventilator needs, they would need to actually fully take parental rights away in order to actually assume responsibility of care in a group home setting. I mean, we haven't actually come across that particular scenario. It's an interesting concept, but I think we leave it up to CES to determine, right, what they're going to do with the parent. It's about what's in the best interest of the child and where is the most appropriate setting for the child in our minds. I think it's also important to recognize that we are a unit like of N of ones. So every family that comes to us has unique challenges, whether that's around the medical complexity, whether it's around the psychosocial complexity. So I think at this point, it's very difficult to make generalizations. We certainly have used CAS, we certainly have involved them in supportive capacities. There have been times where parents have given up their parental rights in order to be able to access different supports and funding opportunities through CAS. So
but it's very difficult to make generalizations because every single person that has come through our unit really has been very unique, as I'm sure it is at SickKids as well. I think the other piece is that I think there has been more of a process that is now going into that pre-tracheostomy stage, so that parents are making a more informed decision when they are moving forward with the decision to initiate trach and ventilation. And of course, people change their mind and things change and things happen. But we haven't really encountered that as much now as I think there may have been in the past, because I think people are making are more informed when they're making that initial decision.
There's a shift in expectation, right? So once part of the decision-making process is the expectation that with that decision, you need to take your child